Assalamu alaikum and good evening. I'd like to invite you all to our today's renal pathology session, which is hosted by PHA and sponsored by United Hospital and Incepta. We thank Nafisa and Sajjad Hossain for arranging the posters and the meeting. And we are extremely happy to have three distinguished speakers and four panelists. So our first speaker is Dr. Tanveer bin Latif, MBBS from Dhaka Medical College, MRCP. His specialty is certified in nephrology from UK, and he is the senior consultant nephrology in United Hospital. So Dr. Tanveer is going to give you first overview of renal pathology, and then Dr. Sinha Ray is going to give two illustrative cases, and finally the expert comes in, Dr. Shari Amin. We do have four panelists. They're very well known. Dr. Nazrul Islam, he is MD Nephrology, and he's the chairperson of BSMMU Nephrology. And then we have Dr. Qazi Shanur Alam. He's MD Nephrology, FRCP, FASN. He's also Vice President of Bangladesh Renal Association, and he is the head of Department of Nephrology, National Institute of Kidney Disease and Neurology. Then we have MD Nazrul Islam. He's also MD Nephrology, and he's the head of the Department of Nephrology, Dhaka Medical College. And then we'll have Professor Nurul. He's MBBS, FCPS, MCPS, FRCP, MD Nephrology, and FASN. He is the head of the Department of Nephrology at Chittagong Medical College. So the talk is divided in three parts. So first, we'll get an overview of nephropathology. This is a basic by Dr. Tanveer bin Latif. There are two cases. And finally, we talk more deep into MGRS. So this program is designed for our students. We'd like to encourage all our students and nephrology trainees and fellows to post questions. Please feel free to post questions. Hopefully, we can answer all your questions. Okay, without further delay, I would like Dr. Tanveer bin Latif to start his presentation. Tanveer.
Okay, thank you for the introduction. Assalamu alaikum. Good morning and good evening to different parts of the world. My presentation will be very basic, as I have said, what a nephrologist needs to know about nephropathology. So, why we do it? It's to reach an exact diagnosis, to determine the nature of therapy, and to decide whether treatment is going to work. Is there any active lesion, chronic lesion, and maybe some genetic assessment? So biopsy varies all over the world because there is opinion and there is no clear evidence when you have to do a biopsy. So the biopsy rate varies all over the world. So this is a bit of Latin alert message. We know that this is the risk of bleeding is quite high, and most of the nephrologists know that. And every kidney biopsy might cause bleeding, but renal histopathology is fascinating. But everyone needs to answer a question: is that how will the result of this biopsy affect the treatment plan and the likely outcome of this patient? So this is very important. So there are many approaches. We commonly apply the percutaneous one because this is preferred as this is less invasive. But the other methods which are more invasive are also there. The instruments that are used most of the time now, the automated spring-loaded biopsy guns, it is usually 16G. I myself use ultrasonography, and probably everyone in Bangladesh, we use ultrasonography. My technique is not real time. I mark it and then when I approach with a needle, it is actually without the ultrasound, where I first mark the area with an ultrasound device. Renal cores are found, and usually 2 to 5 passes are enough. More passes might lead to bleeding. So this is what we get. These are the cores of renal tissue. Bedside microscope, 10-time magnification. There is an arrow pointing towards glomeruli. So the light microscope, this tissue goes into the formalin for immunofluorescence to nanosaline, or sometimes the Michel's transport medium. And for electron microscopy, neutrally high, but there are techniques where transmission electron micrograph can show the lesions from the formalin fixed tissue as well. So the stains that we use for light microscopy, the basic ones, trichrome, H&E, PAS, silver, and Congo red. For immunofluorescence, GMA immunoglobulins, C3, C1q, kappa lambda, albumin, and fibrin, and 4 special stains are there. Electron microscopy actually is there for a while, and it is recommended that it should be used more frequently, especially for the rare diseases like Alport's or thin basement membrane disease, and the fibrillary and immunotactile diseases. Again, very basic. So this is a capillary loop. This is the podocyte, and these are the food processes. This is the endothelial cell. This is the mesangial cell and the mesangium, the urinary space, and the arterioles, and the proximal convoluted tubule, as you can see. Very simple. So in light microscopy, the structures that we look for at the glomeruli, tubule, interstitium, and vessels, we ask what kind of stains we are using, the trichome, whether it is H&E, PAS, silver, or special stains. In light microscopy, first, trichome stain, it is used to have overview, like here, which is a Masson's trichome, 3 stains. The blue ones are the fibrotic areas, and the red ones are not. So it's used to see the fibrosis level in a tissue. The PAS, H&E, PAS stains are used commonly, but now we are using in Bangladesh in different centers silver stains as well. This is important because they stain collagen, and it complements PAS and detects the double contours, breaks, holes, and spikes on the basement membrane, and also stains different nodules. So this is a very basic thing. This is how an H&E stain looks like, and this one is a PAS stain. So the PAS stain actually shows the membranes, the basement membranes, and also the tubular brush borders. Well, so PAS is a reasonable compromise between H&E and silver. The silver stain, it stains the collagens, and it shows the tissues where there is collagen deposit and fibrosis. A very normal glomeruli under electron microscope, and we will see some of the samples afterwards. So the nephrologists usually ask the questions to the pathologist. They are, what is the diagnosis? How active is the lesion? Is there any ATN? How much scarring has occurred? Is it treatable, or is it too late? So these are the basic questions that I always ask when I try to read histopathology report. So we have a lot of things to contribute in the scenario from the clinician's point of view. Actually, you know that all these clinical parameters have implications in renal biopsy interpretation. Everything, whatever we have from the history, age, sex, ethnicity, whether it is AKI or CKD, what was the initial indications of biopsy, hematuria, proteinuria, race creatinine, and the prognostics, and the clinical features of edema, whether the patient has hemoptysis, because this have implications with under-associated vasculitides, maybe, whether comorbidities are there, diabetes, hypertension, lymphoma, etc. Drug history is very important because one could be looking for drug adverse effect on the kidney interstitium. And of course, this battery of tests like urea creatinine and proteins, C3, C4, electrophoresis results, ANA, anti-dsDNA, and the newer anti-PLA2 and anti-GBM. These are very important elements or the piece of the puzzle that needs to be solved. Sometimes the histopathologists don't get this very often, but we need to make the maximum effort so that the pathologists get this information. These days, maybe in advanced part of the world, it is very easy to get these through the electronic medical records, but we still need to communicate with the pathologist in a manual way, but we still need to do it. This is a debate that is going on recently, that so far the histopathology discussions and prognosis and management was pattern-based, but there has to be etiology in our reportings because many of the etiological aspects are more clear now. So there is an article or paper from Mayo Clinic and RPS consensus are saying that the diagnosis should include etiology and should be etiology focused, and so that the treatment is more mechanism based and more rational. So actually, I was inspired by this paper, which was probably published 2015, where they are saying and proposing this concept of etiology and pattern of histopathology together. And so simply, GN is actually as inflammation with increased glomerular cellularity, and cellularity is reflected in different patterns. These lead to a pattern of sclerosing GN, but the similar pathologies might result in similar pattern. For example, MPGN. It could be hepatitis C virus or C3 glomerulopathy presenting with the same pattern. So etiology has to be in the diagnosis. And etiology can be identified in majority of the GN now. So they're proposing that they should refocus and systematically incorporate them into the biopsy report. So that's their proposal. They have divided the GNs into 5 types. As you can see, the immune complex, the post-immune, anti-GBM, monoclonal immunoglobulin GN, and C3 glomerulopathy. One of the limitations is that they don't have membranous nephropathy and other photocytopathies incorporated into this schema. So the immune complex is the largest group, where this is IG nephropathy, IG vasculitis, lupus nephritis, and infection-related GN. They are all immune complex. The post-immune ones are the ANCA-associated vasculitis. The anti-GBM is the sole member of this group. And the monoclonal immunoglobulins is also a large group. C3 glomerulopathy with C3 GN and dense deposit disease. Whatever the etiology, the pattern could be histologically variable. The most aggressive ones are these two, as you can see, because they are necrotizing presenting. And the other groups are also very large. And please note that this thought process starts with the immunofluorescence study because it starts with the immunological classification. So what we need is a good immunofluorescence microscopy, which is the prerequisite for diagnosis. And the advantage that they're saying that this placement in one class means that the other class of GN can be excluded, so that the evaluation and diagnosis and management is even more correct. As I have said, the largest group of their schema is an immune complex mediated group, and the ANCA-associated group, anti-GBM group, and the C3 group, C3 glomerulopathy are the other groups. So the next question that we ask is how active is the lesion? And here the answer lies or can be answered through the pattern of injury. And we are familiar with pattern of injury. If it is presenting and necrotizing, it is very severe and acute. Diffuse proliferative, and if it is exudative, this is of course acute. Membranous proliferative patterns are sort of both active and there's some chronic elements. The mesangial proliferative ones are mild yet still active, and the sclerosis means that this is irreversible chronic GN. But one should keep in mind that the multiple patterns can be present in one slide. So that report is proposing that the basic structure of the kidney biopsy report should have primary diagnosis in the form of the disease process. For example, IgA nephropathy, lupus nephritis. The pattern of injury should not be the sole diagnosis. There should be histological scores and grades as is available in different GNN diseases like Oxford classification, MEST-C scoring, and of course the additional features like if the vascular sclerosis and clinical modifiers like hepatitis C virus or staph cellulitis. For example, if someone is having IgA deposits and it is a diabetic patient having staph infection, likely that is infection-related IgA deposits. The secondary diagnosis, the mean is that is not part of primary diagnosis, like diabetic glomerulosclerosis. This can be there as well, and there should be a narrative or a comment that will clarify the morphological basis of primary and secondary diagnosis. The clinical pathological correlation should be there. Those prognostic information should be there. Differential diagnosis and, of course, references should constitute a good kidney biopsy report. For example, this one. This one is a kidney needle biopsy, and it is an ANCA-associated GN. That is the primary diagnosis. The pattern is necrotizing and presenting GN. Class is focal because it is less than 50% gloom involved. And of course, some additional information like the clinical features of granulomatosis with polyangiitis and extensive, maybe some extensive ATN, and of course, the total chronicity grade, which can be used. It is mild because it is 3 out of 10. This should, an ideal biopsy should look like this. So, from they sort of gathered some of the data from the Oxford classification of IgA nephropathy and the ICEN-RPS LN classification that how to define the glomerular lesions. Mesangial hypercellularity, we all know that it is more than 3 mesangial cells per mesangial area. This is mesangial hypercellularity. We know about the crescents. So we have 3 kinds of crescents, like cellular, fibrocellular, and fibrous crescents. And the crescent, are actually extra capillary cellular proliferation that comes from the visceral epithelial cells, which is it is cellular if the constituent cells more than 50% are cells. So this is cellular crescent. When there is a mixture of cell and matrix, this is fibrocellular crescent. And the fibrous crescent, which is a chronic change, it is when it is more than 90% is matrix. This is actually a fibrous crescent. Endocapillary hypercellularity means that there is an increased number of cells in the glomeruli capillary lumina with narrowing of the lumen. Fibrinoid necrosis is a disruption of GBM with fibrin exudation. Sclerosis is the obliteration of the capillary lumen by increased extracellular matrix. This will be further clarified when I show some slides. The definitions of glomerular lesion. The minimal mesangial GN means that the glomeruli is normal, but the mesangial immunoglobulin deposition is there on immunofluorescence. Mesangial proliferative means that is purely mesangial hypercellular. Active lesion, which we often look for, are the endocapillary hypercellularity, fibrinoid necrosis, crescent, rupture of TPM, karyorrhexis, which means breaking down of a cellular nucleus, subendothelial deposits by light microscopy. Necrotizing GN means segmental or global fibrinoid necrosis. Crescentic, we'll call a GN crescentic when more than 50% of the glomeruli are involved in the crescentic process. NPGN is both mesangial and endocapillary hypercellularity and thickening of capillary wall by subendothelial immunoglobulin or complement factors. Exudative GN means when more than 50% of the cells are neutrophils, as in infectious GN. Sclerosing GN, when you can say that glomeruli is sclerosed, GN means that there's glomerular sclerosis, fibrous adhesions, and fibrous presence. These are all irreversible sclerotic changes. So when we look at light microscopy, we can separate, or even we can divide the slide into glomeruli, tubular interstitium, and vessels. As we look for, we say whether it is global or segmental changes, focal or diffuse changes, what kind of hypercellularity is there, mesangial or endocapillary, whether there are presence in the glomeruli, fibrinoid necrosis, mesangial matrix, how is the matrix, mesangial matrix, whether there is mesangial lysis, how is the GDM like, is there any double contour and disruption and movement capsule. We also look at the tubular interstitium and the vessels. For example, here, if you look at this slide, you see 4 glomeruli. Only this one is involved with a sclerotic process. So it's a focal lesion. It's Jones-Silver stain because it's only not less than 50% are involved in the process. This is not global but segmental because one segment of the glomeruli is involved. So this is segment. And if you look that it is also a silver stain, and there is increased matrix and obliteration of the lumina as compared to these lumens are open, but here you don't have any open lumen. And this one is a global sclerotic lesion because this glomeruli is globally sclerosed. So this is not segmental. This is from this is an FSGS from long-standing hypertension. This is also a Jones-Silver stain. Again, a segmental lesion, which is a perihyal segmental sclerosis. It is a hyalinosis near the vascular cord. This is a PAS stain. Now, if you look close, that this is a glomerulus. And if you can make it out, this is the crescent. And the crescent, which is an extra capillary cellular proliferation, is actually totally crashing this glomerulus. And you also have this karyovexis, which is the breaking down of the nucleus and also fibrinoid necrosis. Here you see, again, a PAS stain. You see that these are the mesangial areas. And the mesangial areas are showing that most places you have more than 3 cells. So you can call it a mesangial hypercellularity and also some matrix expansion. Also, this is a case of mesangial hyperplasia. If you look at, this is a Jones-Silver stain, as I have said, that this stain stains the basement membrane well. The basement membrane is thickened, and if you go close, you will see the spiky appearance. The spikes are the areas where they take up the silver stain, and where there is no stain, these are actually deposits. Another one, which is also a Jones-Silver stain. This is classic double contour here. You see that this is intramembranous deposition of substances or immune complex, giving rise to this trunk-tracking appearance of the basement membrane. Again, this is an endocapillary proliferation. You have a lot of cells within the glomerulus so that they are lobulated in appearance, reminds me of this vegetable, which is a cauliflower. So this may be MPGN. This is fasting. Now, if you look at here, now this is glomerulus. Now we will look away from the glomerulus, look at this interstitium, and you will see these are the tubules, and the whole interstitium is full of mononuclear cells. The tubular lumen surface of cells. So this is interstitial nephritis, and this cause could be so many of the drugs can cause it. This is IFTA, meaning that this is interstitial fibrosis and tubular atrophy. And this is a spectacular color, almost looks like a painting. The blue ones are the fibrotic areas, and the tubules are stained red, which are also showing tubular atrophy because the cells are black. And the glomerulus is also sclerosed. This is ATN. This is an H&E stain which shows the tubular epitheliums. The tubules are flat and loss of nuclei, and there are tubular and interstitial infiltrate as well. If you look at these, the tubules are full with the casts, and this is a light chain cast nephropathy, H&E stain, and this here you have the fractured appearance, which is also very typical of this kind of light chain cast. And as we have said that we look at the glomerulus, the tubules, the interstitium, and of course, blood vessels are also important. This is a it is a blood vessel, as you can see, and there is an extensive myointimal proliferation and narrowing of the lumen. It is a case of complete microangiopathy. So now comes the question of immunofluorescence, because immunofluorescence, everything, many of the etiological classifications and reports start with immunofluorescence. So as I have said, the common stains that are used are IgG, A, M, C3, C1q, kappa lambda, very important, and fibrinogen and albumins. Always the report should address glomerular tubules, interstitium, and blood vessels separately, as is true for light microscopy. And the intensity of the staining is reported as negative 1+, 2+, or 3+. The staining pattern is defined sometimes and described as granular or linear or smudgy. Location, whether it is focal or diffuse immunofluorescence, staining, segmental or global, mesangial or glomerular is important, and sometimes in the interstitium and tubule as well. The thing is that sometimes when there is a segmental sclerosis, they might get staining, immunofluorescence staining, even if this is a polyimmune GN. So you can have a look at this image, spectacular image. This is C3 deposition. This is intensive immunofluorescence, and it is chunky and irregular capillary loop kind of deposit. This is the mesangial and coarse deposit. They are not following any loop pattern, so they are in the mesangium. This is also C3. This is coarse and mesangial, so location is important. But this one is capillary loop, but this is granular. And this is IgG deposition. This is very typical, and this is the linear IgG deposition, which is anti-GBM disease. This is called a starry eye distribution along the basement membrane, which is here. You can see the starry eye deposition that may be found in post-streptococcal GN. I'm trying to show some of the examples, not all of them, meaning that the location and the nature of deposit is very important in immunofluorescence. Again, this is an IgA nephropathy. The mesangial IgA deposits here, not the capillary loops. So the location is important, and we know that IgA nephropathy starts in the mesangium. So as I have said, that IgA nephropathy can be easily diagnosed from immunofluorescence because this is mesangial dominant or co-dominant Ig deposit. Lupus nephritis can be diagnosed from immunofluorescence because this is mesangial and capillary wall and full house deposit. Everything is deposited in lupus. Infection-related one, the capillary wall, IgG and IgM, but in case of staph infection, the deposit could be immunoglobulin A. In possible ones, you won't get any immunofluorescence staining. The intensity can be negative to 1 plus, but sometimes falsely in the necrotic areas, the immunofluorescence staining will be present even if it is autoimmune. So better watch out for that. In anti-GBM disease, intense and diffuse linear IgG, very characteristic of anti-GBM disease, but it is also possible in diabetes. Monoclonal immunoglobulin G is important because then you can stain them for kappa or lambda, and if you find that there is a restriction that it is either kappa and mainly lambda that is restricted, you can say that this is the immunoglobulin is monoclonal in origin. C3 glomerulopathy, we're talking a lot about C3 glomerulopathy these days. And here, the sole staining thing is C3 staining, which exceeds by 2 orders of magnitude compared to the other immunofluorescence staining. So the thing that we don't have in Bangladesh is electron microscopy, but these days, some of our tissues are ending up outside Bangladesh where they have electron microscopy. I have minimal experience with electron microscopy. I have 1 or 2 of my reports interpreted under electron microscopy from my neighboring country. So this is important. In this article, they're saying that 20% of the renal biopsies cannot be diagnosed accurately without electron microscopy. They are recommending that for all native kidney biopsies should undergo electron microscopic examination. And during the selection process, the glomeruli selected should be similar to what was used in light microscopy. Otherwise, you cannot compare the light microscopic finding with the electron microscopic finding. And sometimes it is possible that the paraffin embedded tissue that we use for light microscopy can be reprocessed and used for electron microscopy as well. The glomerular deposits, location type, quantity, size, and substructure are what we look for under electron microscopy. The architecture of the GBM, whether it is thin and thick, duplication, rupture can easily be seen. And the endothelium, the comment on mesangial matrix, and of course, importantly, the podocytes, whether they are preserved or effaced, microvillus changes, they can be seen under electron microscope. And of course, the tubular epithelial cells and tubular basement membrane as well. So again, let's see some of the images. This is a normal one. We have minimal experience looking at electron microscopic slides because we don't use it often. This is from a book. And this is a normal one. This is, you see here, the dark ones are the RBCs. So you are within the blood space that is capillary lumen. So outside lies the podocytes and inside the endothelial cells and in between the basement membrane, which will be more visible here. This is normally this is the basement membrane and the food processors are here, but here the food processes which are here are all effaced. This is a photocytopathy, of course. This is the basement membrane. This is an RBC. This is the capillary lumen area, and this is the belly space, and this is the RBC. So this is food process effacement. Now, this is again a basement membrane. This is the capillary loop. This is the immediate space, so this must be the podocyte. So the deposit, which are electron dense here, deposits here, are sub-epithelial. Again, this is a capillary loop, an RBC. These black dots are the electron dense deposits. And this is the basement membrane. This is underneath the podocyte, so they're sub-epithelial deposits. Now, this is, as you can see, this is the deposit. This is the whole thing is the basement membrane. So the deposit is within the two layers of the basement membrane. And what extra you have got here is an interposed cell, which is here. And so this is an intramembranous deposit of MPGN pattern. So again, another slide, electron microscopy. This is a capillary loop. So this one is the endothelial cell. This is the leukocyte, and this is public platelet. And this hump is interesting and important. This indicates an infectious etiology, which is sub-epithelial. So the key diseases that we can learn from electron microscopy. It confirms that electron is deposited of the immunocomplex GN, monoclonal IgGN and C3GN. Immunocomplex GN is mesenterial and endocarpally wall electron dense deposits. MPGN deposit is subendothelial. If it is infection, as I have shown, it is subepithelial harm, but this can also occur in C3GN. And some of the GNs like fibrillary GN, immunotactoid, and amyloidosis, you should look for the fibrils, which are substructures, which the electron microscope can show you. And of course, in antivascularitis and anti-GBM, there is no electron dense deposit. In every, the secondary diagnosis should be reported as well in biopsy because this is a coexisting lesion and they do not form any primary diagnosis. Like a GN can develop on top of a diabetic glomerulosclerosis. And tubular-induced stenotic disease or vascular disease not related to primary disease like drug-induced interstitial nephritis, AKN could be there as well. Or this could be the primary diagnosis because this was the indication of biopsy in the first place. So this secondary diagnosis will then become primary diagnosis, and you might find some glomerular changes, which could then be secondary. So, however, glomerular findings known to be etiologically related to primary disease should not be reported as primary. Okay, so as I say, when I read the biopsy report, what do we expect? So a biopsy report at the end should contain the summary of biopsy findings and discuss how they relate to clinical presentation, differential and why particular diagnosis was favored, evidence supporting or opposing each potential diagnosis, and score, grade, prognosis, and risk of recurrence on allograft. These should be reported in biopsy report, and we should be reading this as well and try to learn extensively what the histopathologist is trying to say. And that is what I meant by saying what a nephrologist should know about nephropathology. Thank you very much. Here I end my presentation.
Thank you so much, Tanveer. It was a wonderful overview of nephropathology. Especially you touched the basics of kidney biopsy as well as the staining. It's very important to understand the staining because you only see certain structures with certain strain. Then you touch on the basics of proliferative GN versus crescent and the necrosis. Finally, you also gave you an impression about why immunofluorescence and electron microscopy is important. Because we are on a time schedule, I and Dr. Sinare, actually this is a working day in USA. I will invite him to come and start his presentation now. So Dr. Sinare is Assistant Clinical Professor of Clinical Medicine at Creighton University School of Medicine. He graduated from Kolkata National Medical Center, and then he did his residency at Interfaith Medical Center in New York. He was also the chief resident there. He then did his fellowship from prestigious University of Kansas. He recently completed a critical care fellowship. He's triple board certified in internal medicine, nephrology, and critical care medicine. One of the very few nephrologists who actually actively practicing critical care. He is my colleague and partner, but I won't hesitate to say he is one of the finest in the business. So here I present Dr. Abhishek Sinare, MD. Avi, please unmute yourself.
Can you hear me now?
Yes.
Oh, thank you for this kind introduction, and thank you, Dr. Latif, for such a wonderful introduction to glomerulopathology. So my job here is to give a couple of challenging cases which kind of incorporate this few of the same things which Dr. Latif was mentioning, and how this biopsy changes the management, and how different pathology can present with the same histology in renal biopsy. On the other hand, same disease can present with a different glomerular pathology. So let's, without further ado, let's start with the first case. It's a 48-year-old male truck driver, had no documented past medical or surgical history because he has never seen a doctor since age 9. He's not on any medication. He presented with hypertensive emergency with a blood pressure of 232/128, and he has shortness of breath. He had a low urine output for the last few days, which he attributes to poor oral intake because of persistent nausea. His social history was positive for active smoker. He smokes more than a pack per day, and he has occasional use of alcohol. These are some routine labs which was done in ER on that day, and I have highlighted those which are positive actually, or abnormal. So in CBC, hemoglobin was 5, platelet count was 94,000. In chemistry, patient had an anion gap metabolic acidosis with serum bicarb of 17 and corrected anion gap of 19. His BUN was 102, creatinine was 11.5. Urine analysis did show 3 plus blood and 3 plus protein, but no evidence of infection. Microscopy reported as 5 to 10 RBCs per high power field and had granular and RBC cast present. The spot urine protein creatinine ratio was 15.1. The coagulation panel was normal, INR was 1, had elevated pro-BNP at 20,000. EKG showed LVH with repolation abnormality. Chest X-ray has pulmonary vascular congestion. So patient was admitted in the hospital, was started on IV Lasix drip after an initial bolus, along with metolazone. For pulmonary edema and hypertensive emergency, in addition to the diuretic, patient was also started on nitroglycerin drip. We sent some anemia workup, primarily to look for intravascular hemolysis. Haptoglobin came back as less than 8 or undetectable. LDH was elevated at 1088. Total bilirubin was normal. Coombs test was negative, both direct and indirect. Peripheral blood smear did show 6 to 8 cystocytes per high power field. Interestingly, patient did get some blood transfusion in the floor and required 5 units of blood transfusion to bring the hemoglobin from 5 to 7. Unfortunately, even with Lasix and metolazone, patient didn't start to make much more urine and acidosis was worsening, so we started him on hemodialysis after placement of a temporary dialysis catheter. So what the patient presented with is a hemolytic anemia with evidence of intravascular hemolysis, thrombocytopenia, a kidney injury, which we do not know whether it's acute or acute on chronic or just chronic, proteinuria, and hypertensive emergency. All this points towards thrombotic microangiopathy. Now, hypertensive emergency in severe cases can cause thrombotic microangiopathy, and we need to know which one is first, the chicken or the egg. So we decided to go for further workup for thrombotic microangiopathy. And thrombotic microangiopathy has many flavors. It can have HUS or hemolytic uremic syndrome, sometimes with infection or without infection, which we call atypical HUS, or TTP, or drug-induced or pregnancy-related. But the most concern was TTP at this point, because the one thing was that the mortality with TTP is somewhere around 70 to 80%, even with best supportive care. So we, and the plasmic score for this patient was 5, which is indeterminate. So we started on plasmapheresis just to be on the safe side. The treatment was well tolerated. Platelet improved marginally at 112,000. LDH improved to 308. Hemoglobin, haptoglobin increased to 86. The serologic and infectious workup of GN was sent along with ADAM-TS13 level and stool workup for the infections, which all came back negative. The complement, especially the C4, was marginally depressed at 16, but C3 was 80. Hematology was consulted and a renal biopsy was done. So coming to the biopsy, light microscopy, 38 glom. Dr. Latif was just saying that to tell it is an adequate biopsy sample, we need at least 10 glom. So it was a good biopsy sample. Let's start from there. Out of 38 glom, 2 were globally sclerotic. There was significant mesangial sclerosis with segmental, well-developed nodules, which were both PAS positive and silver positive. So this is a PAS stain, and you can see those mesangial sclerosis and kind of nodule-looking appearance. But more importantly, there was segmental to near global intraglomerular thrombi. You can see it here, with few thrombins even in the arteriolar level, which you can see here. The GBM was thickened. This could have been a better picture. I did not have got a best picture of that GBM double contour. But if we see closely on the third picture or the left lower bottom picture, we can kind of see that there are certain areas where there is some GBM duplication. There was no crescents, no necrosis. There was mild 10 to 15% of interstitial fibrosis and tubular atrophy. The immunofluorescence has 1+ IgG, 1+ IgM, and maybe slightly increased C3 deposition. But now to say it's a C3, we have to have two grades higher. So if it's 1+ IgG, we have to have 3+ C3. It was not that bright, but you can see the C3 had pretty good mesangial deposition here in the immunofluorescence staining. So the primary impression was basically this is a thrombotic microangiopathy. The EM was still pending at that point though. So after a couple of days, the ADAM-TS13 level came back, which is 67%. Now, we all know that for TTP, ADAM-TS13 has to be below 10%. So it's not TTP. So Plex was discontinued. We thought this might be an atypical HUS, and the genetic panel was sent. And he was started on eculizumab, which is a very costly medication, but we do use it. Unfortunately, the renal function did not improve. He started to make a much more urine, more than a liter a day, but remained dialysis dependent based on the laboratory panels. Finally, the EM results came back. It has 8 glom in the EM sample. 1 of them was globally sclerosed. There was nodular mesangial expansion, as you can see here, and there was few large mesangial and segmental intramembranous deposits. So this is the membrane, this is the podocyte side, and this is the intracapillary side. And you can see there was electron dense deposit inside those inside that membrane. So segmental intramembranous deposit. Now remember the fact that the IF was positive a little bit more for C3, not two grades higher, because it was 1+ IgG as well. But based on this finding with the intramembranous and mesangial deposits in EM and that little bit more positivity on IF with C3, the report was sent as a underlying C3GN. Now we have two different disease pathology on the same patient, has a C3GN and definitely has thrombotic microangiopathy. So we know for a fact that patient had a complement cascade problem. What can cause this complement cascade problem in a patient who had no documented past medical and surgical history? So we did send complement factor H, antibody to complement factor H, membrane cofactor protein, NEF, and MCP genetic testing for atypical HUS, which all came back negative. So we thought might have paraproteinemia. Now, in the beginning, you can see that I have sent autoimmune and infectious workup, but I didn't send the paraprotein workup just because of the age. I am out of 2 big cohort of myeloma, one from Mayo, one from Columbia. Mayo Clinic average age for the myeloma cohort is 59 and Columbia was 58. And this guy was only 48. So I didn't send the paraproteinemia workup in the beginning, but given the fact that I saw that there was some complement cascade problem, we sent those paraproteinemia workup, and surely the SPEP did show monoclonal protein, UPEP also showed monoclonal protein, and the immunofixation came back as IgG kappa. The kappa lambda ratio was 2.35. However, it is not that high because it can be explained with a creatinine of 11. A bone marrow biopsy was performed. Pathology came back as kappa restricted plasma cell dyscrasia. Patient was started on chemotherapy with a VRD regimen. So bortezomib, Revlimid means lenalidomide and dexamethasone. And patient continued on 2 weekly eculizumab in the beginning, and which slowly got tapered off. Unfortunately, patient never recovered the renal function. He is still on hemodialysis, home hemodialysis for 5 days a week now. Now, coming briefly about the complement pathway, we know that there are three pathway. One is classical pathway, one is alternative pathway, and one is the lectin pathway. All three pathway ultimately at the end of the day results into development of C5b9, which is the membrane attack complex, and some byproduct like C3a, C3b, and C5a. In all the complement mediated renal disease, this alternative complement pathway is hyperactive. In our body, the alternative complement pathway is tightly regulated by some activating protein and some inhibitory or regulatory protein. The activating protein are C3 and complement factor B, and the inhibitory or regulatory protein are complement factor H, factor I, MCP or membrane cofactor protein, and factor H related protein. Because of the balance of this both stimulator and inhibitor, the alternative complement runs spontaneously at a very low dose or very low rate, and the resultant production of C5b9 can be managed by their body's own scavenging mechanism. Now, if this balance is disrupted and the alternative complement pathway goes hyperactive and makes more C5b9, that goes beyond the capacity of body's own handling or mitigation system. And then that extra complement cascade subproducts get deposited in the kidney and cause renal disease. It's just like dipping faucet. If you have a dipping faucet in your bathtub, if it drips 5 drops a second, it will be easily cleared by your drain in the bathtub. If it drips 5,000 drops per second, then the bathtub would be full, and then you will see a water splash. Exactly the same pathology. So ultimately, based on the diagnosis, this patient had multiple myeloma-induced underlying C3GN, and that was probably the reason why patient never recovered the kidney function, because the C3GN was probably chronic. Although on the biopsy sample, we did not see much glomerular sclerosis or interstitial fibrosis. On top of that, patient had a paraproteinemia-induced thrombotic microangiopathy. So that is probably the tipping point why the patient ultimately ended up in the hospital. So you see the one patient, one pathology, multiple myeloma, or one disease, present with 2 different pathology in the same patient on the same biopsy sample. So next, moving ahead with the second case, which is a 71-year-old male with progressive renal insufficiency and worsening proteinuria. I first saw this patient in November of 2017. He has a past medical history of hypertension and type 2 diabetes, but no documented micro or macrovascular complication. He had macular degeneration, but no diabetic retinopathy or documented neuropathy or gastroparesis or anything else. Patient also had hyperlipidemia. Creatinine baseline was 1.3 to 1.5, did go up to 2.1 before I saw him. Dipstick was 10-20 specific gravity, had trace to 1+ protein and 2+ blood. I personally did the microscopy. The microscopy did have dysmorphic RBC. There was 5 to 10 RBCs per high power field, but at least 2 or 3 of them are dysmorphic. Spot urine protein creatinine ratio was 0.1 about 6 months back. And then at the time of my evaluation, it was 2.1. So obviously we sent the GN workup. The ANA, dsDNA, hepatitis panel, HIV ELISA, ANCA panel, anti-GBM all came back negative. C3, C4 was normal. Coming back to the paraprotein workup, SPEP increase in beta fraction. Kappa lambda ratio came back as 45.47. The UPEP had some unidentified protein in the alpha and beta region and diffuse expansion of gamma globulin. And immunofixation had kappa light chain monoclonal protein. So first time patient underwent biopsy in December of 2017. The light microscopy had 20+ glom. Again, good sample size. Couple of them were globally sclerosed. So 10% sclerosis. Marked glomerulomegaly, which could be non-specific, has a features of, can be a features of diabetic nephropathy, but can be features of many things else. Loss of nephron mass, obesity, smoking, all this can cause glomerulomegaly. Mesangial region that is diffusely expanded with PAS-positive material, it just looks like Kimmelston-Wilson nodule. Interstitial fibrosis and tubular atrophy, 15 to 20% of the biopsy corrects. So this was actually just like the picture which Dr. Latif showed on initial presentation of a diabetic nephropathy. IF had 5 glom, 1+ IgG, diffuse. IgM was also positive, C1q, C3, and kappa lambda was negative. The Congo red stain was negative. The reason why Congo red stain was done because we had concern of paraproteinemia based on the workup or pre-biopsy workup. The EM showed diffuse expansion of mesangial matrix. There was no immune complex deposition, and there was moderate effacement of epithelial food process involving less than 50% of the capillary surface. And there was some evidence of hyaline arteriosclerosis. So the final diagnosis which came out on that biopsy was advanced nodular diabetic glomerulosclerosis without any evidence of paraprotein-related renal lesion. And there was concern for secondary FSGS based on the epithelial food process effacement of less than 50%. But we didn't stop there. We did a bone marrow biopsy. The bone marrow showed a normocellular marrow, had a kappa monotypic plasma cell neoplasm comprising less than 10% of marrow cellularity, consistent with MGUS. And I know for a fact Dr. Amin will say it's MGRS, but I could not prove it at that time with the renal biopsy. But monoclonal gammopathy of unknown significance or renal significance, whatever you take, and no evidence of amyloid deposition. Hematology was consulted as because the renal biopsy was negative and the clonal cell was only less than 10%, so it doesn't fit into the criteria of multiple myeloma. So the decision was made for careful monitoring without starting any chemotherapy. So now, fast forward for the next 1 to 2 years. Patient was placed on dual RAS blocking agent, so ARB and a mineralocorticoid receptor blocker, and along with SGLT2 inhibitor. The blood pressure and the A1C was pretty well controlled over the next 1 year. Despite that, he continued to have progressive renal disease. Creatinine reached up to 3.5 and protein creatinine ratio was up to 4. In December of 2020, patient went to North Dakota for ice fishing. Presented to the ED over there with a pain in his right arm. Imaging showed a mass eroding the bone along the right mid-shaft humerus, which was subsequently biopsied. And the biopsy came back as plasmacytoma. So patient came back from North Dakota and was obviously seen by hematology and oncology. In setting of prior diagnosis of plasma cell dyscrasia with skeletal involvement, he was started on Cybor-D regimen, but only got basically 1 month of treatment and then switched to Revlimid. During that 1 month, the creatinine, which was 3.5 before, now improved to 2.8. But post-Revlimid initiation, patient had some worsening of renal function. Subsequently got hospitalized with nausea, vomiting, poor oral intake, and generalized not feeling well. On admission, the creatinine was up to 4.2. There was some suspicion that patient has Revlimid-induced ATN because kidney function did worse after initiation of Revlimid. But the protein creatinine ratio was 5.8. Now, I understand this could be an overestimate of underlying proteinuria, given the fact that patient has an AKI. But I still decided to do a repeat biopsy. So this is 3 years after the initial biopsy. So the repeat biopsy was March of 2021. There was total 25 glom, 5 globally sclerosed, 1 glomeruli showed segmental sclerosis. So now the glomerulosclerosis is more of like 21%. Extensive, well-developed nodular diabetic glomerulosclerosis. There was component of ATN as well on the light microscope. IF had only 3 glom, 1 of them was globally sclerosed. There was linear GBM deposit 2+, and tubular basement staining as well with IG. There was trace mesangial staining with the C1q and C3. IgM was negative. We did IgG subtype staining with 1 through 4, and there was no strong positivity with one over the other. So the prelim impression was advanced diabetic glomerulosclerosis with some evidence of ATN, but it was just not making sense to me. So I called Dr. Nasser. I'm sure you guys know him. He's the head of nephropathology at Mayo. And I discussed in detail about my concern of paraproteinemia-related kidney disease in a background diabetic nephropathy. So he decided for this paraffin immunofluorescence, which Dr. Latif briefly touched on, after antigen retrieval, which also known as pronase digestion, before repeating the immunofluorescence again, and a careful evaluation of EM sample. So we did that. The paraffin IF now came back as more severe staining of IgG in the mesangium and focally along the GBM and tubular basement membrane. Unfortunately, the kappa or lambda was both negative. When we did the EM, there was 4 glom, 1 of them was sclerosed, but the rest showed extensive powdery deposits, as you probably can recognize in this picture, along the mesangium as well as along the GBM and tubular basement membrane. Some of this monoclonal type deposit also found around the arterioles in the interstitium. So then we changed the diagnosis, which was the patient was labeled as advanced diabetic nephropathy for last 3 years. Now it changed as monoclonal immunoglobulin deposition disease, or MIDD, with a gamma heavy chain type. The kappa lambda both were negative. The IgG subtype staining was negative, and I literally asked Dr. Nasser why it was negative. So he thinks that it's a result of truncated protein and not detected with those antibody. There was advanced background diabetic glomerulosclerosis, and there is no question about that. But there was some evidence of ATN as well. Good thing, good. Patient was subsequently switched back to Cyborg regimen for almost a year, and then slowly switched over to, again, Valcade, Revlimid, and dexamethasone regimen. And I was also getting the Zolindronate for the skeletal lesions. In addition, he was kept on dual RAS blockade with ARB and mineralocorticoid receptor blocker, as well as SGLT2 inhibitor. Never required dialysis. Slowly improved his renal function. I last saw him about a month ago. His creatinine now is 1.8, and urine protein creatinine ratio is 0.2. So that's a good story. So the reason why I want to present these two cases is that both the patient had one disease, myeloma, presented in 3 different renal pathology. When we think about myeloma-induced renal disease, we think about cast nephropathy. Patient coming with AKI has a history of myeloma, or we diagnosed myeloma. Okay, cast nephropathy is our first differential. Yes, about 60% of the cases, patient will have cast nephropathy. But there are so many different pathology, as you can see in this slide, that can happen. Some of them are paraprotein associated, and some of them are not. The paraprotein associated one is cast nephropathy, and you saw a beautiful picture in Dr. Latif's presentation. There are some organized deposits like amyloid, fibrillar regions, where we can see fibrils, or microtubules like immunotactoid or cryoglobulinic GN, or crystals or inclusions like light chain cast nephropathy with crystals or histiocytosis, or like non-organized deposit, like the second case of mine, where there is a monoclonal immune deposit disease, and which was probably heavy chain deposition disease. There might be light chain deposition disease as well, or light and heavy chain deposition disease, or PGN-MID, which is a separate entity altogether, or immunoglobulin related MPGN, which also started a new era in the MPGN classification of renal pathology. And then C3GN with paraproteinemia, which our first patient had. And also the thrombotic microangiopathy. Sometimes the paraprotein load is so high that patient's blood becomes viscous and can have hyperviscosity syndrome. But even without paraprotein, there are features where patient can have renal disease in presence of myeloma. If patient does have severe hypercalcemia, that can cause ATN or ATIN, acute tubulointerstitial nephritis. There is a patients with a B-cell lymphoma or multiple myeloma can have plasma cell infiltration inside the kidney. We have a patient who currently in our dialysis unit who had a history of low B-cell lymphoma, developed renal failure from plasma cell infiltration. There's also nephrocalcinosis that can cause renal injury. Drugs toxicity, like in our patient, Revlimid caused ATN and caused a little bit of worsening of kidney disease. Or the patients who get stem cell transplant, post-SCT, we can develop membranous GN as well as thrombotic microangiopathy. With all this thing, I would like to stop here and would like to invite any question you guys may have.
Well, Dr. A, this is absolutely fantastic. I mean, you saved 4 kidneys and 2 human beings just because of your persistence. Now, for our students and fellows, this is the highest standard of practice of nephrology. See, he never gave up. He even went back after 3 years to get an answer. This is how nephrology should be practiced. Now, I know Dr. A is on today, and he has to hit the road in a few minutes. Since he invited for any questions, so please feel free to ask any questions. We have only a few minutes before Dr. Shahriar Amin will come in. Okay, questions? Let me see if anybody posted anything. Okay, Professor Nurul Huda, do you have any comments?
Thank you very much, Imtiaz Bhai. You hear me?
Yes,
I can hear
you. First of all, I thanks both the speaker Tanvir and Abhishek for their nice presentation. Especially Tanvir highlighted the basic things of the nephropathology, and Abhishek uttered two cases, but very high standard case. I should say, because first of all, we think the one diagnosis, but finally we have to change the diagnosis after, and they did a lot of test, a lot of investigations and rebiopsy as well. This is only possible, I think, in USA and Western world, but this is not possible in country like Bangladesh, and I also think India. It is also not possible.
Yep.
So this is a very informative lecture, I do believe. In future, I think we may think like in this way, when we think that after 3 years we will do the rebiopsy and our diagnosis should be changed, and finally we change our medication and patient improves. That is the hope.
Yep.
And that is the hope, and I think we'll in future we think in this way, and we should not give up our patient. We will fight with our patient, and we shall try with our best to do like Abhishek. He gave us hope to do rebiopsy and change the diagnosis. Thank you very much for your excellent, I would say, excellent and outstanding clinical presentation.
Thank you.
Thank you.
I just want to have one comment. I have spoken to multiple renal pathologists because of our practice, and I am sure Dr. Amin will agree with me in this situation. If you ask a pathologist, if you have to get one biopsy on a patient, which biopsy you will get, and they will always answer, I want a repeat biopsy. There are two important reasons for doing a repeat biopsy. One, sometimes the diagnosis does change, and if the first biopsy results is not as per your expectation or what you are suspecting based on your clinical or lab parameters, the second biopsy can definitely change the diagnosis or the management. Number one. Number two, even if the first diagnosis is right, the progression of the disease over the course of next few years is very important. Like the first biopsy on the second patient, if you remember, there was only one glom out of 20 was sclerosed, so about 5% sclerosis. But think about the second biopsy, there was 5 or 6 got completely sclerosed out of 20. So you can see how is the progression, how aggressive you would be in terms of management that can protect their kidney and can save them from going into dialysis or renal replacement therapy.
Yes, thank you. This is very important for anyone anywhere in the world.
Fascinating.
Well, I'd be hitting the road, but I would be available over phone. If there is any question comes up at the end of the Dr. Amin's presentation, I would be more than happy to take that.
Thank you, Abhishek. I really appreciate your a compilation of these fascinating cases. I think my students and fellows, they are like lightning struck. I would let them absorb some, and hopefully Dr. Shahriar Amin will make it a little simple for them. So drive safe, but please stay in touch. So
Thank you so much.
now,
I appreciate it.
yeah, thanks a lot. And now I'm gonna go to MD Shahriar Amin. He's MBBS from Dhaka Medical College. Really proud of him. He also has a PhD in molecular and cellular biology from University of Ottawa. Then he did his fellowship in nephropathology at the famous Mayo Clinic, as well as a fellowship in cardiovascular pathology at Mayo Clinic. I'm going to read a lot of the other stuff, not to embarrass you, Shahriar, but I think our students need to know what can be achieved by 1%, alhamdulillah. So he also is FCAP, FRCPC, FASN, Assistant Professor of Pathology, West Virginia University, Section Chief Cardiovascular, Renal and Transplant Pathology, Medical Director, Autopsy, Renal and Electron Microscopy Lab. He has multiple awards, and especially mentioning a Society of Cardiovascular Pathology Young Investigator Award in 2015. He has 30 publications in high-quality peer-reviewed journals. He has authored in books and theses. He has about 17 grants and ongoing research. I don't know why one person can do all these things. So he has conferences, abstracts, and publications, about 53 of them. He has given high-quality lectures, about 39 of them. Again, Sharir, we are very proud of you. So he's going to talk and hopefully make monoclonal gammopathy of renal significance a little easier for all our students. Sharir, please go ahead.
Assalamu alaikum. Thank you very much, Imtiaz Bhai, and thank you very much for inviting me to this planetary meetings. Actually, it's a great honor to be part of it here, and hopefully I can, do my best. The first two presentations were definitely excellent. Thank you, Tanvir, for going over the basics of renal pathology, and then Dr. Sinha, you for those two, really those are eye-opening cases actually. Like, because what I'll be talking, you'll see down the road. So not to take too much time, I'll can you all see my slide and my screen?
Yeah, we
Yes.
can.
Okay. Excellent. Thank you. And can you see me moving this cursor?
Yeah, we can see that.
Excellent. Okay. So what I'll talk today is basically about, we'll go over the general concept of what is MGRS, what is monoclonal gammopathy of renal significance. We'll talk a little bit about pathogenesis, some common clinical features, how the kidneys get involved by paraproteins, and then we'll talk about some of these diseases. What are paraproteins? Again, as you know, these are basically immunoglobulins, and there are light chains that are in the blood and in the urine. And basically, whenever people have a lymphoproliferative disease, like this could be terminally differentiated B cells, lymphomas, and stuff like that, you end up having excess production of these paraproteins in the blood, and some of them go into the urine. The incidence is quite higher in the Western countries. It's about 3 to 4% in people over 50 years, and if you count more than people who are more than 70 years old, it goes up to about 5%. Men are usually more commonly affected than women. I think there are not probably very good studies about incidence in Asia or in Bangladesh, for per se India per se. So I think this is something that people should be looking into, because in the past, again, our population, when I was in medical school, I remember the average age of the people used to be 50, 60 years. But now that people are living longer, people are not dying from infectious diseases. I think that's why you need to look into, you'll see more incidence of these diseases in the coming days. So again, just a quick overview. What are these immunoglobulins? So you can see that's just the common structure of an immunoglobulin. You have got a heavy chain, and then you've got the light chains. The 4 or 5 common heavy chains are, again, I can't remember, it was GAMED, G-A-M-E-D, and then you've got the light chains, kappa and lambda. So what happens in these monoclonal gammopathies is, again, because of this underlying lymphoproliferative disease, lymphomas, or whatever you want to call it, the underlying disease, basically you have excessive production of these monoclonal proteins. It could be either of these ones. The most common one obviously is IgG or IgM, but we also have sometimes IgA, and then this can be coupled to kappa and lambda. And not infrequently, we do also sometimes see just IgG only, like kappa only, lambda only, IgA only. So depends on whatever the clone is producing. So it doesn't mean that if you're seeing an IgA and kappa, it's not MGRS. It could be, because it depends on whatever that clone is producing. So what are these? These are, again, these are basically, I consider them as, bullets, as fire things going in the blood, and they may not be detrimental to health or not causing any lesions. And that's why in the past people used to call them monoclonal gammopathies. You know that they are there, they are not causing anything. So people used to call them MGUS, of undetermined significance. And I think it was a good name, because back then you didn't know whether or not they were causing any end organ damage. But now, with with more knowledge, we now know that many of these paraproteins do actually cause end organ damage. So what are some of these diseases? Again, for the sake of time, I'm not going to go into details. You know these things, or you should know, most of the students. So some kind of any lymphoid or lymphoplasmacytic proliferations. Myeloma is the big one. Everyone knows about it. Plasmacytomas. There are, again, some less common neoplastic conditions, POEMS, TEMPI, and so on. So the hematopathologist would be, more well versed in those, and they can tell you a bit much more in details about individual of those diseases. So what we'll do today is we are going to talk about what these light chains actually do to the protein, to their kidneys. As you can see, almost 80 to 90% of these light chains have or do cause pathologic alterations based on studies in the past few decades. 70% of all these nephropathic light chains can cause tubular injury, and up to 30% lead to glomerular alterations. So it's not insignificant. Once people who have light chains going, circulating in the blood, they do a significant amount of them do cause pathology. And and you can see this evolution of our understanding just by looking at the PubMed circulations and research in this area. You can see like the number of publications have significantly increased. So in the 1950s up to coming to the 2000s, we barely knew much about them. But now in the last 10 years, look at the explosion in publications regarding this field. This is again MGRS only per se. The previous one was just in general, but here in MGRS also you can see like most of these articles are coming up in the last 5 to 10 years or 15 years or so. So why is it important to know? Again, because these light chains, they do cause progressive damage. At the time when you know them, you may not be aware of them, but it's important to keep following up these patients because of this progressive damage, and they do not undergo spontaneous remission. People used to think angioedema is just going to stay there. No, it's not true. And even if these patients end up having a kidney transplant, for example, right? So they end up having end-stage renal disease. You should remember this thing because this disease is going to recur in the transplant. So it's very important to keep that in mind. And they have a poor response to conventional immunosuppression. Why? Because again, it's not going to go away unless you treat the disease. If you don't take away the cause, if you don't take away the clone that is producing these light chains or heavy chains or whatever these monoclonal proteins are, you're not going to be able to treat it, right? It's going to come back and forth, and just immunosuppressing the patient is not going to work. You're just going to cause more problems, infections also. And so they do ultimately require some therapy. So that's why, again, we call these monoclonal gammopathies of renal significance. And by this, basically, we mean that there are kidney lesions which is caused by these monoclonal immunoglobulins. And the patient has some kind of underlying gammopathy. So again, something is small doesn't mean it's not harmful. Again, you remember the Star Trek figure, Master Yoda, or this is a small dog chasing a hippo, or even this is a small ant attacking the elephant. Again, these are examples of that. A small amount of light chains could also be very potentially toxic or nephropathic. So I'm going to skip some of these slides. So what we'll do today, during the course of the next probably 20-25 minutes or so, we'll try to take a journey. Imagine yourself as if you are the light chain or the heavy chain or that monoclonal protein, and we'll try to go from the arteries, take a journey through the glomerulus, then to the tubulointerstitium and all over, and see in what ways we can cause damage, and hopefully it would make it easy for you to understand the pathogenesis of the disease. So in each step, we'll go over some of these diseases, what happens at the vascular level, what happens at the glomerulus level, and then the tubulointerstitium. So let's start from the blood vessels. So the blood vessels, again, are the first place where you have them, right? You are producing them somewhere in the body. These light or heavy chains of these monoclonal proteins, they're coming through those arteries and arterioles. So the first place to take the brunt of the disease in the kidneys is going to be your blood vessels. So what do we see there? So one of the first things that we probably encounter in this is TMS, like thrombotic microangiopathy. So 10 to 15% of patients, again, this is a case study by Dr. Sethi from Mayo, again, about 10 to 15% of them have an underlying MGUS with patients who've got just a TMA, and about a quarter of them are usually more than 50 years old. So in a classic TMA, this is what you would see, the involvement of the blood vessels. You can see this, fragmented RBCs in the wall of the vessel, kind of onion skin lesions here. And then once they go from the arterioles into the glomerulus itself, you start seeing this fibrin thrombi, right? So here in these cases, we are not necessarily seeing any changes or any, like kappa light chain or restriction or anything like that. Your immunofluorescence studies in these cases may essentially be negative, although we know that this patient still has an underlying MGUS. So in these cases, again, the TMA is one of the initial manifestations. So this is actually kind of interesting, brings into perspective Dr. Sinha's case when he was showing the C3 deposition. So that comes in again a bit later in the course of the disease. So one of the, again, as I'm saying, so very early on in the disease process, you are probably seeing just the TMA or thrombotic microangiopathic changes. Once these light chains have passed into the glomerulus now, right? So you can remember the histology of the glomerulus itself. You have got the mesangial spaces, you have got the mesangial cells, you've got the endothelial cell here lying there, and this is your vascular space, and then you have got the Bowman's space up here, and these are your podocytes. So now what is it going to do? So these light chains are here, and now their first thing, they're going to either start by depositing in the mesangium, or they can cross through deposit like membranous deposits here around the glomerular capillary walls, or they can again form fibrils like in amyloid here, or as you can see in PGN-MID, they can start, causing so much damage that the cells or the body starts to show proliferative changes. So we'll go through some of these features in the next few slides. So again, depending on what are the light chain sequences in those paraproteins, what are the what is the the local microenvironment like? It depends on a lot of factors. What you'd see, you may have different types of presentations in different types of these diseases. So cryoglobulins are one of the, again, the light chains. Remember, we are taking a journey. So some of these light chains can behave, or some of these paraproteins, I won't say light chain anymore, some of these paraproteins are going to behave as if they are cryoglobulins. So they can basically precipitate at 4 degrees and dissolve at 37 degrees. So that's the definition. And since we are talking about MGRS, these are essentially the type 1 monoclonal immunoglobulins. Usually the patients have an underlying MGUS, Waldenstrom, multiple myeloma in up to 10 to 15% of them. So what do we see here on the, what do we see in the presentation? Again, you can see renal involvement, either nephrotic range proteinuria or renal failure in about 3/4 of these patients. But again, see no extrarenal symptoms in almost half of them. So you have to have a very high degree of clinical suspicion whenever you're encountering one of these cases. And 80 to 90% of them in patients with cryoglobulin, they will have these vasculitic features, purpura, rash, things like that. So non-specific kind of when they come to the GP or even to a specialist, sometimes some of these presentations can be very non-specific. Unless you have a very high degree of suspicion, you may not catch them. In the context of Bangladesh, of course, I'm not talking about just MGRS. HCV is a very common one causing these cryoglobulins. So keep that in mind. I'll present a case here. This is a 55-year-old man, had a history of Hep A, hypertension, alcohol abuse, basically comes in with headache, nausea, and vomiting. And then the GP noticed that he has got some kind of rash. They did some labs and find that the creatinine is elevated, essentially just refer it to the nephrologist. The nephrologist does some more workup and they find that he has nephrotic range proteinuria. And while the SPEP and UPEP is still pending, they decided, well, I have enough reason for this patient to get a kidney biopsy. Let's see what's going on. And here in our center, I try to follow the same way we did in Arcana, same day. So a lot of times my biopsy results will come up even before you have any other results. So this is some of the rash that this patient had. And when you look at the glomes, you can see this. You can see some of this gloom. This is an H&E stain. You can essentially see these loops are full of some cells. And again, there are some RBCs here, but these are not RBCs. You can see this stuff that's kind of red is not RBCs. So it's a proliferative feature. It's not a crescent, but you can see even on this H&E that there's some endocapillary proliferation going on. Here is the PAS stain, and you can see large clumps and stuff here within the lumen of these glomeruli. This is a silver stain, and you can see that they are non-argyrophilic. See, the silver stain typically stains your basement membranes black, but here you can see this stuff that's within these loops is not picking up the silver stain. So it's a non-argyrophilic kind of deposits or within the loops. So we do the immunofluorescence studies, and here we can see that this basically essentially is staining strongly for IgM and kappa. And this is a very important distinction. I know in Bangladesh, many places don't still do light chain immunofluorescence for kappa lambda, but I think if you have to choose what stains I want to bring in for kidney pathology, definitely bring in your kappa and lambda. Even if you cannot afford or you don't want to do the rest of the stains, the five most essential ones I would suggest would be A, G, kappa, lambda, and C3. If you don't have the other ones, you don't want to do them, doesn't matter too much, but these five should be there. So this is an electron microscopic stain. Electron microscopy, you can see the GBMs are nice, and Tanvir already showed you some of the basic morphologies here. So here, basically, I'm going around the GBM itself. So one thing I tell everyone whenever you're assessing electron microscopy, first orient yourself, right? So these are your podocytes. So here's the urinary space. This is your endothelial aspect here, and these large clumps kind of showing also some fracturing artifact. These are your deposits, the IgM lambda kappa deposits in this case. They don't show any substructure. So basically, it was a cryoglobulinic GN. The next case is a PGN-MID, proliferative glomerulonephritis with monoclonal immunoglobulin deposition. In this case, basically, you have proliferative features within the glomeruli. You can see crescents. You may see segmental endocapillary or mesangial proliferation. That is Dr. Nasser from Mayo. When I was a fellow there, he was one of the first people who actually described a series of these cases when he was in Columbia University, and that's why we used to call this when I was in Arcana. It's not official, but we just called it Nasser's disease. So this disease appears to be more common in females, about twice more, rarely associated with myeloma. However, important to know is that it's high recurrence rate in the allograft. So 50 and if you have a patient who had actually PGN-MID and you did a transplant, half of them may fail within the first 3 years after the transplant. So it's important to know those features, and we'll go to a case. So this was a case actually I had here in West Virginia. You can low power, you can see already there is some chronicity. You can see more blue, right? So when you're looking at the this is the trichrome stain, you're expecting mostly tubules and glomeruli, but you can see that there is a lot of blue in between, so suggesting that this disease has been going on for some time. It's a chronic stage at this point. When you look at the glomeruli, you can see does it look normal? No. So you can see the loops are here. This is a nice glomerulus, but as you can see, this segment here is kind of quite proliferative. A lot of cells. I don't like so many cells being there. Your glomerulus, when you're looking at it, it should be essentially mostly empty spaces. But here I'm seeing a lot of proliferation, a lot of cells here. There is both mesangial and also endocapillary proliferation. Some of these are again even essentially starting to touch the Bowman's capsule here. You can see these kind of cells trying to, hey, calling these parietal epithelial cells, hey, come on, help us out. Something is going on. This is a PAS stain of the same case, and you can see here it's starting to almost form like a baby crescent kind of thing. But I'm not seeing any like large deposits that we were seeing like in the cryo case before. This is another section, another glomerulus in this same patient. You can see mesangial proliferation. See, this is the pink areas here. These are the mesangial areas. And you can see more than 3 cells in most of them. And you can see also some segmental adhesions. See, this is the arterial pole of this, but here on this side, you can see that there is segmental adhesion to the Bowman's capsule, essentially segmental sclerosis. So you look at the immunofluorescence, and you can see here that there's the IgG, and it's kind of, there's a kind of like a smudging type of non-specific, very, it's not necessarily granular, it's not also like a transparent like amyloid. It's got, you know, some coarse granular deposits, mostly in the mesangial areas. But what is striking is that the lambda is essentially completely negative. There is no staining for lambda. So IgG is positive, there is C3 usually goes with it, and then the kappa is there too. So it's an IgG kappa restricted. So the next step we would do as a nephropathologist, we want to see, is this IgG, is it monoclonal or polyclonal? And we did that, and here's the IgG subtypes, and you can see that it was only IgG3 staining. IgG 1, 2, and 4 were negative. Now we go to the electron microscopy. Again, you can appreciate this deposits here and on the mesangial and paramesangial areas. See this here? These are your deposits. So again, orient yourself first. This is your RBCs, the dark black things. These are your RBCs. This is your Bowman's space. These are your capillary loops. And then these are your endothelial cells. And here is your deposits. These are your deposits, mesangial, paramesangial type of deposits. Okay, so that was a case of basically proliferative glomerulonephritis with monoclonal immunoglobulin deposits. The next case is another entity, again under this same MGRS. These are membranous nephritis with masked IgG kappa deposits. This is kind of like the one that Dr. Sinha was presenting the first time, so I'm not going to spend too much. This case, these patients are usually more in females, again, 4:1, a younger patient group. So on light microscopy, you may see some chronicity, like here, quite a bit of chronicity in this patient. But you know, on your initial stains, you'll probably see just the GBM looks a little bit thin. I can appreciate some thick, you know, some pinholes along this peripheral capillary loops and so on, but not much proliferative changes, no crescents, nothing like that. So I'm wondering, well, is this a, you know, healed membranous or what is going on? Then we look at the electron microscopy, and you can see all these dark deposits within the GBM. Immunofluorescence in this particular cases is usually going to be negative because again because the deposits are masked. But then so we do this. Here's the immunofluorescence study, and you can see that the initial immunofluorescence is essentially negative. But then you do the paraffin retrieval, that's when they light up. So you've seen these deposits now on electron microscopy. So we go back to the slides and then say, okay, let's do the paraffin retrieval or after pronase digestion, and you can see that it now lights up these deposits. Okay, any questions so far? I'm kind of going in a row bunch of cases. So. All right, so next we'll talk about a little bit about amyloidosis. So now again, think yourself is still in the, as if you are the light, the paraprotein going through the glomerulus. So I've passed through the mesangium, I've passed through the loops. Now I'm going into the interstitium, right? So the paraprotein is now starting to go into the interstitium, and one of the ways they deposit here is in the form of amyloid. So in the Western countries, amyloidosis due to, you know, light chains, be kappa, lambda, and so on, are one of the most common causes of amyloidosis here. So 70 to 90% of the cases of amyloid that we see in USA, Canada are usually, or even in Europe, are essentially because of, you know, light chain or, you know, heavy light chain kind of combination of amyloid deposits. In Bangladesh, if you see amyloidosis, probably is going to be a lot more because of infection associated GNFOF, because of infections and so on. That would be another talk. We'll go over those different types of amyloid in another session. So most of these are usually because of just one light chain, and in most cases, lambda light chain is in, you can see it in about more than 3/4 of the cases. But again, it's not uncommon, it's not unusual also to see a combination of heavy and light chains or only heavy chains. As you can see on this graph here, these paraproteins do cause a lot of pathogenicity. The kidney is definitely one, but even more than that, they affect the heart. So a lot of these cases, patients has heart failure, or they have a progressive, restrictive cardiomyopathy, that kind of scenario, and they come in and the clinicians are wondering what's going on, and they find out that the patient has an underlying gammopathy. This here we'll talk about a case of this is a 60-year-old man, Caucasian. Again, has the usual, very common comorbid conditions, hypertension, diabetes. Many nephrologists may even think, hey, you have got diabetes for 50 years. It's probably diabetic nephropathy. There's no need to do a biopsy. We'll just follow you up. Or, but then this patient was having progressive proteinuria, and the nephrologist was a bit more curious. Basically, you have to push the boundaries. Essentially like a diabetic patient, if the diabetes is very well controlled, he has not had much albuminuria and so on, be a bit more inquisitive. There could be something else going on. So he got a biopsy here, and this is the biopsy, and you can see, like, again, a lot of chronicity. You can see tubular injury even at this low power. You can see a bunch of sclerotic glums, but even at this power I can see something is going on in this glomerulus. Part of it looks kind of funny. So when you go on higher power, you can see that the mesangial areas, the glomerular loops, are kind of quite thickened. They don't look like the normal ones that Tanvir showed earlier, right? So the mesangium is quite expanded. It's not because that there's too many cells, but there is this homogeneous kind of a stuff in there that is, expanding these areas. You look into the blood vessels and you can see the same thing. The blood vessels have this homogeneous, glassy kind of material deposited within the walls. And you even see the same stuff in the interstitium. So we do the PAS stain. So if this is like, let's say, anyway, so you can see the PAS again. These are not picking up the PAS stain much, so they are not PAS positive. And on this trichromatin, you can see that they are more like, they're not like collagen. Collagen is usually very dark blue, and these are kind of not that color. And lastly, but most important, again, silver stain is very useful. You can see that the silver stain shows, again, this sometimes these patients you can confuse them with diabetes, because you can think that the mesangium is being expanded by diabetic, but you can see it's completely non-argyrophilic. So it's not necessary always to have electron microscopy. I would say 80%, 90% of our diagnosis we can reliably do without EM. So if you pay attention to the silver stain, this would tell you that this is not diabetes, because you can see that the silver stain is not staining those pink areas that you saw on H&E. See, the H&E was showing something is stuff in there. If this was diabetes, you'd expect all of these areas to become dark black color, just like this collagen. So we do the immunofluorescence here now, and you can see that the kappa is essentially negative. But when you look at the lambda stain, whoa, there's this kind of, homogeneous deposits in the wall of the vessels, within the mesangium, in the wall of the glomerular basement membrane, and also some in the interstitium. Now, a word of caution, if you do not have fresh tissue left, then your immunofluorescence is not going to be useful in these cases, because from my experience in Arcana and also other people, we've seen that on paraffin block, if you do pronase digestion, this does not work for amyloidosis. In that case, if you want to type the type of amyloid, your only option is going to be left is doing mass spec or another biopsy with fresh tissue. So this is the Congo red stain. Again, we use it as a kind of, you can see the gold standard. It's not necessarily the gold standard, but we use it as a confirmatory. And you can see that it shows this kind of pink, rosy pink, red color when you stain the amyloid cases with the Congo red. And this is what you see under polarized light. It's kind of, usually the books say it's apple green birefringence. Yes, we do see some apple green, but I would say it's more like aberrant birefringence. Normally, if you polarize it, you'd probably see silver color from the collagen like this here, but this is aberrant birefringence. Yes, if it's a very good case, you can bring it out to show the apple green color. So what do they look like under electron microscopy? So this is again a recent case I had here. And you can see the GBM here again. This is the RBCs within the loop. You can see the food processes are completely effaced. Okay, so well, yeah, so that explains the proteinuria, right? 4 grams proteinuria seen, what is it called? Minimal change disease, let it go. No, but then you look up here, the mesangium, what is good? This is stuff in the mesangium. Right, so this could be, they can give you in the board exams, and you can see, look at this in the mesangium. This color, this stuff here has a different intensity than the GBM itself or the collagen. So you look at it on higher power, you can see these amyloid fibrils. Okay, so amyloid. So now the light chains have been able to cross from the blood. They went all the way through the interstitium, and now they are through the GBMs, and now they are starting to deposit in the interstitium and depositing in the form of amyloid. So survival in amyloidosis is again cardiac. If the heart gets involved, is actually quite worse. In kidneys, if you cannot diagnose it early on, survival is good. Many of these patients would end up becoming dialysis dependent or needing a renal transplant. So I'm not going to go into those details. This will be an amyloid talk. Okay, so other glomerular diseases that you can see in the context of MGRS or because of monoclonal proteins could be IgA nephropathy, membranous nephropathy, fibrillary can sometimes also present in the form of monoclonal relations. This is an example of IgA. We know that IgA is very common in Asia, especially in in the eastern countries, Japan, China, but also I'm pretty sure it's quite common in Bangladesh. So if you know it's the case of IgA, also pay attention to your kappa lambda. Make sure that it's not monoclonal, especially in a more elderly patient. So these are examples. There are case reports of case series of patients with monoclonal IgA. Again, I'm not going to go into details of treatments. Then there is also like monoclonal membranous, right? So you have a membranous, typical or classic membranous nephropathy, but then you look at the immunofluorescence, you see that the lambda is negative, kappa is positive. So again, pay attention to those cases. And then these are, I had a case here also, like this one is basically a fibrillary glomerulopathy, but again, it's restricted by either kappa or lambda or one of the major proteins. The next we'll go is now the paraproteins. They've crossed from the glomerulus, they've crossed the interstitium, now they are in the tubules, right? So now they have been able to go from the, they've crossed all the glomerular barriers. They're fine now, they have come into the tubules. Now what are they going to do here? Now here, once these paraproteins are here, now what does the tubule do? Most of the proteins or the stuff that comes into the tubules gets absorbed back. So they're going to go through the tubular lumen and go back into the blood, or they can stay within the lumen. So the diseases that we'll talk in the next few minutes are going to be where the paraproteins are basically causing tubular interstitial damage. So the first thing that they would do is start damaging the tubular epithelia itself, right? So you can see acute renal failure just because of those light chains of paraproteins going through and causing simple tubular injury. Sometimes in some of these cases, you can see that the immunofluorescence will show that there is some kind of light chain, but you don't see necessarily amyloid deposition, not necessarily deposition within the basement membranes or anything like that. So we call them light chain deposition by immunofluorescence only. Like you can see here, the immunofluorescence, you can show that this patient had a lot of lambda light chain within the blood, and you can see that the tubular epithelia are kind of full of the lambda light chain. So pay attention to your interstitium. Whenever you're looking at immunofluorescence studies, make sure you look at both the tubular interstitium, not just the glomerulus. So you can see here the kappa is essentially negative. There's nothing in the tubules, but you can see the lambda lights up all those proteins going through the tubules. Now, once they start causing damage, that's when you see tubular injury. So here is a case of a tubular injury. You can see the lumens have become ectatic or dilated. The brush border is kind of missing or almost very, and some of these tubular epithelia are starting to become cuboidal, right? Now, all of these cells are supposed to be tall columnar cells with a nice brush border. We are not supposed to see this lumen. So these are all, again, telltale signs of tubular injury. So in this particular case, those light chains have crossed from the glomerulus. They are not causing any glomerular damage. See, they've not, the glomeruli are essentially unremarkable, but they've come through the tubules. They have come into the tubules, are causing damage into the tubules now. So this patient was having basically creatinine was slowly increasing from 1.2, had gone up to 1.5 in a course of 3 to 4 years. And the urine analysis did not show any proteinuria because most of them were getting reabsorbed. But when you did the biopsy, you can see tubular injury, and you can see that there is, this light chains within the tubular, within the tubules. Again, this is the PAS stain showing this light chains, basically essentially causing tubular injury per se. But immunofluorescence, EM, everything else is negative. And you can see even there's nothing in the GBMs, nothing in the tubular basement membranes, but you can look at the tubules. Oh, is this normal? No, I'm barely seeing any brush border left. See this tubular epithelia? They're supposed to have a nice microvilli, nice brush border here, but you can see that there is no brush border left. They're kind of becoming epithelialized. We'll call this epithelialization of the tubular epithelia. The other thing that you can note, there is no crystals, nothing inside them. So what is this light chain in this particular patient is causing, they are basically just causing simple tubular injury. They're not depositing anywhere. Most of them are getting reabsorbed by the body. So when you do a analysis or urine analysis to see is there proteinuria, there's nothing there. And then you look at the GBMs and TBMs, they're not even depositing there. Somehow they are, bypassing all these checkpoints, basically going through and coming back into the body. But in the process, they're causing tubular injury. And this is not very uncommon, quite not uncommon, again, if you can catch it early on. Some of these paraproteins, however, end up getting deposited within the cells. So that's when you within the epithelia. So again, a lot of this depends on the microenvironment, right? So how the cell, how the patient behaves. It depends on patient factors, the microenvironment in the tubular interstitium, inside the cell, what type of light chains or heavy chains there are. So a lot of these factors play together and leading to these different types of physiologies that we see. So in light chain tubulopathy with crystals, these light chains now are stuck within this epithelia. Now they are not being able to go back into the blood vessels, into the capillaries anymore. They are stuck here. And what are they doing? They are becoming crystallized. They are stuck here, they are forming crystals. And that's what you're seeing here. In this case is like, the light chains have become crystallized within the epithelia. So this is again some pictures. Again, these are rare cases. These are less common. In most scenarios, in most patients, they'll just go back into the capillaries and go into the circulation again. But in some patients, they may end up staying within the tubular epithelia in the form of crystals. And here you can see this, light chain crystals within the tubular epithelia. And an electron microscopy would be helpful here. Again, you can see these crystals. These are not mitochondria. You can see they have got this kind of a straight borders, edges. So these are what your crystals look like within the tubular epithelia. Now, pay attention again. There's nothing in the TBMs, right? They're all just stuck. The TBM is essentially nothing showing up there. And the glomeruli were again unremarkable. These are again some more pictures from a paper, and you can see that they can, just staying within the tubular epithelia in the form of crystals. Now, what happens in light chain deposition disease? Now they have crossed these light chains of paraproteins. Now they have gone through the cytoplasm of the tubular epithelia. Now they are starting to get scrutinized by the tubular basement membrane or the glomerular basement membrane, and that's what you see is light chain deposition disease. That's what we call. So we see here in this disease granular deposition of these monoclonal proteins in the wall of the GBM or in the tubular basement membrane. So again, here you can see by light microscopy lots of tubular injury, right? The tubular epithelia is essentially become simplified. There's no normal tubular epithelium left. I mean, they're still there, but then the TBM is also, by light microscopy, you won't see much here. When you do the immunofluorescence, you can see that the staining is not inside the tubular cells themselves. The staining is essentially either in the glomerular basement membrane like here, or in the tubular basement membrane. See that? So it's just the basement membrane is staining, and you look at the lambda is essentially negative. Now you look at the electron microscopy, you can see here that, wow, there's something that's at low power, it may look, there's some mesangial proliferation and so on, but you look at more closely, you can see there's this kind of dense or powdery stuff that is along the GBM. It's not like a, it's not the same as a, membranous or anything like that. So this is this black stuff that's deposited along the glomerular basement membrane. This is a high power view. Again, you can see that this kind of powdery deposit. This is, of course, a very good case. In more earlier cases, you won't see nice like that. It will be more fine granular debris, like the one that Dr. Sinha showed earlier. So this is and then you look into the tubular basement membranes, and this is again a classic case or well-established cases. You'd see kind of this kind of granular debris in the tubular basement membrane. But notice the tubular epithelia themselves, there's nothing there. But what is going on here? There's extreme tubular injury. They don't have any microvilli, no brush border, nothing. They have got their severe tubular injury, but the proteins are essentially just depositing in the tubular basement membranes or in the glomerular basement membrane. So again, as I was saying earlier, a lot of this depends on the sequences in those light chains, the paraproteins, plus the interactions in the microenvironment of the cell in the basement membranes, and a lot of also patient factors as well. What the patient is eating, maybe whatever they are eating causes some kind of configurational change in the proteins. That's why they deposit in some patients and not in others. And then last but not the least, light chain cast nephropathy. Now that light chains or the paraproteins, they've been able to cross all the way from all those barriers from the GBM, TBM, and all those things. Now they are inside the lumen. Now here they are kind of accumulating and causing obstructive casts. There are some studies, that some certain sequences, like this sequence, for example, has a higher affinity for the 10-horsepower protein, and they can correlate with increased cast formation in certain types of myelomas. So a lot of these patients, by the time they usually definitely have a lot of light chains being produced. So by the time they get light chain cast nephropathy, most of these patients have already diagnosis of multiple myeloma. So this is a 55-year-old gentleman. Again, comes the first time he comes into the hospital is when he is basically feeling nauseated, vomiting, and the creatinine at this time it was about 10 or so milligram per deciliter. And you can see even at low power here, you can see these tubules are extremely injured, but you can see in some of these tubules kind of PAS negative casts that have got this kind of a cellular reaction around them. Plus some of them also showing some fracture artifact. Like here is this fracture artifact. You can see this here. This is very classic or typical for atypical casts. So you can see here more of these light chains, and there's the cellular reaction around them. So it's sometimes difficult to determine, is it really a light chain cast versus just a 10-horsepower protein. PAS is useful, but again, PAS, one of the cases I had last month was a PAS positive cast nephropathy. So you have to take a lot of things into consideration, like the cellular reaction, the artifacts, and of course, most but not the least, your immunofluorescence. Pay attention sometimes, again, I tell this to everyone, also our trainees too, the H&E that we get for doing H&E on the frozen sections, and look at it under the immunofluorescence, the H&E stained section. This is what I had here. This is the H&E stained section under the immunofluorescence microscope, and it nicely outlines this fracture artifact in this cast nephropathy case. So again, when you do all the immunofluorescences, you can see that these light chains usually in this particular case was kappa light chain restricted. They're showing the staining for kappa and no staining for lambda. Again, you have to look around. Again, you have to have a high degree of suspicion, not just like one if you have a high degree of suspicion, look around. Sometimes they are mixed with normal casts. So you will see a mixture of both restricted and non-restricted casts. There could be some casts that are positive for lambda as well, but you have to find those specific casts to show that these are the same tubule or same cast, and these are restricted. So in this particular case, again, you can see the GBM is essentially normal. So if I want to show a normal glomerular basement membrane, you can show this one here. See this, the GBM is normal, the food processes are completely standing up, not much effacement, the endothelial cells are normal, podocytes are okay. Then you can say maybe there may be an occasional deposit here and there, but nothing else. There's no mesangial proliferation, nothing. The TBM, again, see, there's nothing in the TBM. So in this light chain cast nephropathy patient, the paraproteins basically journeyed all the way through these, and essentially they deposited only in the tubular lumina. So near the end of our talk, I think I took a bit longer than expected, but again, I think this is a very good paper, the evaluation of MGRS. It's a consensus paper, came out in 2019 or 20, I think, and it's free. I suggest everyone to read this, especially if you're practicing nephrology and you're interested in MGRS lesions and things like that. This is a very good, well-rounded paper, and it tells you exactly about how to, when to consider biopsies, what to do, and it gives you a brief overview of all the different lesions that we talked about today. With that, I'm not going to go into details. We already talked about most of these cases, and I'll finish here and take any questions. Thank you.
Well, thank you so much, Professor Shahriar Amin. As mentioned before, this is a really very deep dive into the world of MGRS. And I particularly like your comment about small things that are invisible can be very powerful. So I wonder how much of the unknown kidney disease by even cannot be explained in kidney biopsy. All these things have underlying monoclonal disease involved. I'd like to invite Qazi Shanur Alam to make some comments. He is head of nephrology at National Institute of Kidney Disease and Neurology. Professor Shanur, are you there? Okay, so I'll then invite Professor.
Thank you, MKS bhai,
Okay.
for inviting me. I was just spellbound hearing the wonderful lectures of Dr. Tanvir Latif, followed by Abhishek, and lastly by Dr. I think Shahriar Amin. Yes. I congratulate all of the speakers for giving this elaborate lecture on this. I should say the some undiagnosed in our country undiagnosed diseases, renal diseases, especially the MGRS, monoclonal gammopathy of renal significance. The fact is that we are lacking the renal pathologist in our country. So sometimes we miss the diagnosis, and we are conservative about the renal biopsies. So we miss the diagnosis in some cases. But from these lectures, I think our students have learned many new things, and especially I myself also learned many new things regarding the MGRS. The first presenter, Dr. Tanvir bin Latif, nicely described the different types of glomerular diseases. Especially the slides were very good. And the second presenter, Abhishek Sinha, his two case presentation is very much inspiring for us, because many of the times we gave up, and the complicated cases we cannot go forward because of lack of investigation facilities. I think with these two case presentations, we can go forward, and we should try to diagnose the cases with etiology, exact etiology. And last one, Dr. Shahriar Amin nicely described the paraprotein involvement of the renal diseases. So what I have learned from this, that we should change our teaching methodology, I should say, because our students are not involved in the and they are not going to the histopathology labs and don't see the slides by themselves. So most of our knowledge regarding the glomerular pathology is theoretical. So I should ask our students to be more involved in the histopathology department, so that they can, what they have learned from the textbooks, they can also see from go through the histopathology slides also. With these few words, I like to stop here. We have other panelists also. Thank you, Imtiaz Bhai, for arranging such an important webinar. Thanks again.
Thank you so much, Professor Qazi Shanur. I think it's a very, very valid and valuable point. Even during my fellowship, although we had world-class pathologists around, I don't think I took advantage of them as much as I should have. I think we need to incorporate the histopathology in the curriculum of our training fellows and MD students, so that they have to go through this rotation from time to time. That's the only way to learn. See, we are learning now, but I mean, I should have learned this 20 years ago. So now I'd like to invite Professor Nazrul Islam. Thank you for being with us, even though he's not feeling very well, but I really appreciate your presence here. He's Chairman, BSMMU. Please, for your valuable comments.
Thank you, Imtiaz Bhai. Can you hear me?
Yes.
Okay. Actually, it is very interesting and interactive sessions. And the three speakers, actually, they explain the whole pathology, histopathology of the glomerulus, primary and secondary. I am particularly very much interested in the very, very underdiagnosed MGRS, because a high degree of clinical suspicion is required to diagnose for MGRS or like that, MGUS, because maximum cases actually underdiagnosed in Bangladesh because we have no electron microscopy, and at the same time the denial of the patient regarding the biopsy and proper timing of biopsy is very important. First speaker, Tanvir Latif, has excellently actually demonstrated all the pathophysiology of histopathology of the glomerulonephritis, and I think this is the ideal way to describe the histopathological changes in the glomerulonephritis. And the second speaker, Abhishek, he is also a very, very, actually, I think his 2 case reports is excellent. And I learned many things from his case reports. The maximum cases, actually, we think that a single disease, we can explain, there's a notion in the past that please diagnose in a single disease, but now it is not right, because a combination of diseases there. So we should think. So the clinical suspicion is required. And the third speaker, Shahriar Amin, he elaborately described all the histopathological changes in the monoclonal gammopathies. And actually, this is very interesting. In Bangladesh, we got many cases of monoclonal gammopathies, and we are frequently encountered, because in the past it was it is our study that the maximum case of gammopathy occurs in the older age groups. But actually, the age limits or age bindings is not so important nowadays. I have find a lot of young patients has monoclonal gammopathy, particularly light chain diseases are there. So I think that our students definitely benefited from this type of webinars, but I myself know a lot, because my second edition of book will coming in the market very soon. And actually a separate chapters is monoclonal gammopathy of undetermined significance. And here we incorporate these things. Actually, I have already been incorporated these things in my book. And I think it will be very much helpful for the readers. Thank you.
Thank you, Professor Nazrul Islam, for your valuable comments, and we wish you all the success. Actually, he gifted me one of the books. It's a very nice textbook. We should all look into that. Now, Professor Shari Amin, there is a basic question by one of our fellow students. Just wanted to know the difference and utility of immunoelectrophoresis versus immunofixation. Can you just explain it in a few words?
So immunofixation or immunoelectrophoresis you'll be doing on the protein on the urine or blood, right? So that will tell you if the patient has some kind of paraproteins in the blood or in the urine. The immunofluorescence is what we are doing on the tissue specimen here, right? So that's when, let's say you have a kidney biopsy, we are doing immunofluorescence to see if there is deposition of those proteins in the tissue or not. So that's kind of like the very basic difference. And another thing I think I would say is, excuse me, for Bangladesh, for example, I know we don't have electron microscopy in most centers, but immunofluorescence is very, very
Exactly.
easy to do. It's very, very easy to do. All you need is the, kappa, lambda, IgA, GM. And don't even bother about M. A, G, C3, kappa, lambda. Those are the 5 immunofluorescences you want. And any histopathology center should be able to do immunofluorescence there. So even if you do not have EM, in I would say 70 to 90% of 90% or more of these cases, you don't need EM. So don't think that EM is a restrictive thing. I don't have EM, I cannot diagnose this. No. I mean, there are, it will give you a bit more clarity regarding what the disease is. But even without electron microscopy, those just some of the special stains and immunofluorescence are enough to be able to diagnose reliably most of these diseases.
Thank you, Professor Sharia. Now, I think immunoelectrophoresis.
Dr. Islam, this is Abhishek. Can I have a small comment
Sure.
just in accordance with Dr. Amin? I completely agree with Dr. Amin. The monoclonal gammopathy of renal significance or multiple myeloma, these diseases are have immune deposits. So IF is necessary. And yes, most of the patients are older. As I have mentioned in my talk, the Mayo Clinic cohort is average age is 59, but average age is just a number. That has a spread. Even in younger patients, we do see this monoclonal gammopathy and monoclonal gammopathy related renal damage. The one thing I must point out, there was a famous article by, I think, Dr. Nasser, when he was in Colombia, that he was blindly seeing a biopsy of patients who have diabetes on their past medical history. 60% of those patients who got biopsied had pure diabetic nephropathy. The rest 40%, half of them had diabetes plus some other alternative glomerular pathology, and half of them didn't have diabetic nephropathy at all and had just pure alternative etiology for their proteinuria and renal dysfunction. So in other words, those patients whom we are thinking that they have diabetic nephropathy, only 60% of them will have pure diabetic nephropathy. 20% of them will have diabetes plus something, and 20% of them will have just something else and not even diabetic nephropathy. And we need to pick up those 40%. So patients especially diabetic patients in a poor country like India or Bangladesh, especially if they don't have associated feature, like if the patient has diabetic retinopathy, the chance of having nephropathy is very high. Okay, this patient, for the sake of saving some money, we may avoid biopsy. Patient does not have any active urinary sediment. Active means I am just talking about hematuria or RBC cast. If the patient does not have active urine sediment, yes, we can spare them a biopsy. But on the other hand, if the patient does have significant hematuria in a patient with diabetes, I will biopsy them every day.
Very valuable comment. 20 years ago, I had a kidney biopsy which showed the patient has diabetic nephropathy. Actually, patient developed ESRD within the next 1 year. This patient never had clinical diabetes. So I was scratching my head, and somebody alluded to an article, and I saw there is a bunch of these cases. Those are quite old, And they said, well, the patient may not have clinical diabetes, but they can become diabetic nephropathy and even end up on dialysis. Actually, I wonder how many of those cases are actually this monoclonal disease that actually never had opportunity of pronase digestion and looking into the monoclonal proteins. So very valuable comment. So yeah, go ahead.
Imtiaz bhai, I just want to comment one thing. Very nice presentation.
Sure. Go ahead, Nazmul. I think you are muted, Nazmul. Please unmute Dr. Nazmul.
Can you hear me, Imtiaz bhai?
Yes, I can hear you now.
Okay.
Yeah, go ahead.
So I think for the residents and the trainees, even for us, I mean, as you're mentioning, and I think Abhishek also was saying, is that, if you look at the biopsies, whenever there's a vague suspicion, vague something like MPGN, which is a diagnosis should not be done by pathologists. I always ask the pathology, can we do a subclassification of the IgG? Because the PGMID sometimes goes undiagnosed. And diabetic patient also, as you're mentioning, the rule of thumb I look at, there's a protein albumin creatinine ratio and the protein creatinine ratio, and the 1:2. Basically for the residents, I'm just going to pull it out the students, is that different features and diabetes. But if you see the protein creatinine ratio and the microalbumin creatinine ratio is not 1:2, that can kind of bring up that suspicion something else you're missing, especially if somebody has nephrotic range proteinuria. I was about to ask the question to the Shahriar bhai about the pathological point of view. Do you have any articles or any evidence that if a nephrotic range proteinuria in diabetes, what is the cutoff that we should think about doing a kidney biopsy to rule out any of the secondary cause like plasma cell disorder or any kind of membranous changes? Because it is not common, but it can sometimes overlap, as we are seeing in these rare cases.
I agree. It's not infrequent. There is a paper from Arcana. I'll try to find it and send it to you or share it with you. And also there's papers from Mayo and other places as well that, the exact cutoff for how much proteinuria you should have to go on, do the biopsy. I think it depends. Now, let's say you have a patient who is young and he's just diagnosed with diabetes, right? And he doesn't have any other features of diabetes, or his diabetes is very well controlled, but he's got severe proteinuria. That would be a high threshold. And on the other side, if you have a patient who's got diabetic nephropathy, he's got end-stage creatinine is going high, slowly increasing over like 30 years or so, maybe my threshold would be less. And even in patients, for example, we are finding out in many patients who have got these comorbid conditions, there are other types of diseases, for example, LAC2 amyloidosis. Maybe another day I'll share some of those about amyloid, different types of amyloid. Not necessarily everything is light chain amyloid. We are now finding there are different types of amyloids, especially in South Asian countries, in Africa, South America, and so on, that they are causing proteinuria. So again, that for diabetes, you have to take into consideration your clinical judgment. Now you have been following a patient for 10 years, 15 years, his proteinuria has been growing slowly from, and most of it is albumin, then yes, okay, probably it's just the diabetic. But if he's something, the proteinuria doesn't make sense, or he's suddenly increased a lot, or those are some of the, I think, points that you have to consider. And again, the deep protein, for example, the deepest proteinuria not necessarily is useful, especially like in MGRS, as I showed in one of the slides. If you just do a deepest stick, and you won't catch the light chains, right? Because the light chains won't show up there.
And also the kidney function, you have to watch it. I think it's a nice presentation for all the presentators. Thank you.
You're welcome.
Thank you for your nice comments. So, Shari, I think the student had a comment, a question. I think the serum protein immunoelectrophoresis, where we are actually separating the protein out to see there is like a higher concentration of band in one area, but we do immunofixation to find the monoclonality of it when we have whether kappa versus lambda chain. Isn't that right?
Yeah.
Okay. So now, since you have knowledge in molecular and cellular biology, can you tell us briefly what is in the monoclonal protein itself, which does a pathological lesion either in the vessels or in the kidney. What is the cellular pathology for this? Why does it cause this?
Exactly. That was the whole point I was trying to, show throughout this talk. It is, to us at the, you can say like, they all look the same, right? If to us, and when you look at it from higher power, everything is light chain or monoclonal, but they are not the same because they have different sequences, right? So the sequences are different between the light chains. So one person's light chain sequence is not going to be the same as the light chain sequence produced by another person. And the same thing, the clone that is producing it, those clones have completely different, we don't know what, and they are neoplastic. So they are tumors, they are producing an abnormal protein, and that we don't, by our assays that we are doing right now, we are thinking that these are all light chains and heavy chains. Yes, and they are, but they have some similarities, but there's also portions of these light chains and heavy chains that have, completely different peptide sequences. So I think those peptide sequences make some of them go to the heart or stick to the heart, some of them go to the kidneys, some of them get stuck in the basement membrane, some of them get stuck inside the tubular epithelia, and others go all the way into the tubular lumen and then are able to get filtered and so on. The other thing, of course, is important is patient factors. So the patient's personal, each person is different, right? So what he eats, what he or she eats, what are the microenvironment within the tissue is also different. So a lot of these things come into play when you have to decide which protein is doing what kind of where it is depositing,
Yeah.
what kind of deposits are seeing. Because like even with the light chains, see some of them form casts, some of them deposit as powdery deposits, some of them become amyloid, some of them become cryoglobulin. So again, all of this depends on patient factors, microenvironment of the tissue itself, and the peptide sequence in those chains.
Very interesting. Thank you.
Sorry,
Professor
I'm-
Shamim, are you there? Simon sir, do you want to make any comments? Sargi achen?
Yes, thank you. Can you hear
Okay.
me?
Yes, sir.
Yes. First of all, I have to give thanks to 4%. Number one is excellent opportunity you are making to hear this knowledge. And this is, you are the person, Dr. Imtiaz, and the PHM. So excellent opportunity. I think 1 year back, you have given this opportunity to us. Yeah. Now, 3 speakers is excellent, more than excellent, I should say. At the age of 71, I'm seeing that what we have learned, we should learn more like this. And first speaker, Dr. Latif from United Hospital, was excellent. Congratulations to him for excellent innovation. Second speaker is excellent, but more than excellent as a case report. I'm so overwhelmed and as amused. So we understand the level of standard of treatment and standard of investigation in our country. Third speaker, Dr. Amin, I think he visited Kidney Foundation by invitation of Professor Harun Rashid. I remember his face and his lecture, and excellent, super excellent. And also the 4 head of the department. I should request the 4 head of the departments of Bangladesh to make the practice of at least monthly, there should be a clinical meeting of this. Because I was in Chandigarh, there was a 15 days, there is a clinical pathological meeting in which the slides was given. That's why I was interested in pathology. I should rightly say, Professor Shahnur, this should be mandatory to the student and in the curriculum. With this, thank you a lot to you and all the speakers. Thank you very much.
Thank you, sir. It's always an inspiration when you join in and you keep learning, which actually forces us to learn more. Dr. Tanvir Latif, you wanted to ask a question, so please go ahead.
Yeah, I would like to know, as Dr. Amin was discussing about you're answering to your last question about the molecular part, because some of the conferences show about a lot with proteomics and all those data, and probably he was talking about those spectacular world of omics and all. Are these things being used in any of the clinical diagnostic scenarios? Because I have seen some of the textbooks are saying that the omics data will be of use in clinical diagnostics.
As of now, to my knowledge, we are not using it yet.
All
So
right.
those would probably come up later, when you're let's say when you're trying to do targeted therapy, maybe 4 or 5 years down the road, hopefully things are changing very rapidly. Things are changing very rapidly, honestly. And so, and now using AI and all those things, you can
Yeah, AI.
actually
Yeah.
at some point be able to do very targeted therapy. A patient who's got light chain cast nephropathy versus a patient who's got a PGN-MID may get completely different treatments, right? So once you have those, well, there's 3 things in this, I think. One of them is collecting the data. The more we know, if we don't even have the patients, we don't have the data to you study on, then you can't do that. Number 2 is to have
Large
an
data
open
set.
mind and push it to get those, tests and studies, and then of course available, whatever technologies we have available, we can use them.
And one
But
simple
right now,
question that you said that, so if we do our the kappa and lambda staining properly, we will probably will not miss the monoclonal gammopathies much, right?
a lot of them, exactly. We should
Okay,
be able to
great.
catch 95% of them.
Okay, right.
Maybe
Thank you.
the rare 1 to 2% where there is, what is it called, masked monoclonal gammopathy, those ones you may miss. But if you're doing routinely kappa, lambda, IgA, GM on all of your samples, you should not miss, at least 95% of them should not be missed.
Yes, because some of the labs in Dhaka are doing kappa and lambda staining quite routinely. So we have hope, I think.
Yes, excellent.
Thank you.
I think ASN is examining a model about getting all the genetic information and other markers that have been studied. They're going to put it together with the AI model and try to use it. And that is still being investigated. Because I think many of the things with proteinuria and nephrotic syndrome, like what is the permeability factor and these things. I mean, we have been doing research on this. We haven't been able to find it. So this is one of the basics of nephrology that is still unknown.
Yeah.
I wonder, Professor Hamid Ahmed, are you still there? And do you want any comments, Professor Hamid, DSMMU?
Yes, thank you very much. I am still here, and I was enjoying. And I had measured myself that I am so lack of knowledge I have got. Today I learned many things from you. Though I am not in Bangladesh, I am in UK. However, I was trying to attend your meeting. NGS actually in our curriculum, it is involved, but not extensively. Actually, we need a nepropathologist. That is the big question, and an electron microscope is necessary. Plus, you have mentioned that AI can help to diagnose glomerulonephritis, particularly subtypes. I don't know where AI is going and where we are going. Time will say actually. However, if you have any opportunity to help us regarding AI and histopathology, please try to inform us. So proper channel, we will be very grateful. Our chairmen and head of the departments are here. They will make communication with you. And thank you very much for all the speakers, as I am enriched by the lectures. So thank you very much for your fruitful delivery. Thank you very much.
Thank you
And,
very
you.
much. I just want to
Hamid.
add one last line. I'm always available. If you have any questions, anything, you can. And nowadays, consultation is very easy. All we need is a scanner in Bangladesh, for example. You can scan the slides. I'll be always more than happy to contribute whatever I can, to help our patients in Bangladesh.
Thank you very much for your broadness. We can ask you some questions by sending our histopathology slides in a scan manner. Thank you. Thank you.
Hello, Shahriar. I am Professor Nurul Huda. Can you remember me?
Yes.
I am from Chittagong. You came.
Yeah, I
I
came
think
there
you
2
belong
years
to
ago.
Chittagong. You came to my
Yes,
room.
yes. Yeah, I know. I remember you. And I remember exactly. And, we were discussing, and then COVID basically disrupted everything.
Yeah. And first of all, I have some question to you. You mentioned 90% of diagnosed light made by light microscopy and electron immunofluorescence.
Immunofluorescence.
Only 10% need electron microscopy.
Even less.
And for this 10%, can you advise the AI? Can AI replace the electron microscopy?
No.
Answer
No.
is no. Answer is
Not
no.
yet. Not yet.
Not yet. Okay. In our pathology, actually, not all pathologists do kappa lambda, but some, most of the biopsy report they do not mention the kappa lambda. Usually, IgG, IgM, IgA, C3, and C1q. That
You don't need even see if you want to talk. If I'd be happy to talk to some of our pathologists in Bangladesh. I would say 99% of the except lupus patients, of course, that's a different story. With non-lupus patients, C1q is essentially negative. I mean, even without C1q, I can really make 99% of my diagnosis. Okay, so that's I sometimes even consider the albumin, fibrinogen. Fibrinogen is important. C1q and IgM are kind of like, I don't know why we even do it. So if you want to advise some of the pathologists or the labs down there, tell them, if you want to save some money, just do the kappa lambda. If those are positive and you want to expand more and see what, then do the IgA, IgG to see if it has something else. If your kappa, because if the kappa lambda are showing deposits, they should be positive, even in IgA nephropathy, IgG, membranous, whatever is there, right? So if you want to save, some money from them, but if you're doing a panel, just do AGC3 kappa lambda. Make sure do not do a kidney biopsy, especially in an elderly or above 40 patient, without doing the kappa lambda.
Okay. And another question is for hepatitis B virus and C virus induced GN. When I think so, a lot of our patients has hepatitis B, C, as well as diabetes. So we cannot differentiate actually. For this, we have to do hepatitis B virus antigen in kidney tissue. But in our country, it is not possible. What is your recommendation?
We don't do hepatitis B testing on the tissue at all, actually, because now if the patient has Hep B, for example, now some of the manifestations in the kidney that you can see is probably going to be either membranous nephropathy, could be, some kind of glomerulonephritis per se, could be minimal change, the different types of manifestations. You don't do HB, SAG, or any hepatitis B panels and stuff like that on the kidney biopsy itself. So you don't necessarily need tissue diagnosis for it. Now, if the patient has renal manifestations, has got hepatitis B, yeah, the kidney biopsy will tell you what kind of kidney disease they have. It won't tell you about whether or not the hepatitis B is causing it or not is a different story. And a lot of times, even here, we cannot make that connection. Patient could be HbSAg positive, could have HCV and so on, but making that exact connection is still, I don't think we are able to do it yet.
And few days back, we have some cases. They have diabetes as well as hepatitis B, Hep B or Hep C positive. And in that cases, you have to, if you start steroid, diabetes will goes up. That's why we have a question: is it due to diabetes or due to Hep B or Hep C? So if you and sometimes Hep B or Hep C, just you treat the Hep B and Hep C. GN will be improved, but some cases you need a special treatment. That is the question. When we will start the special treatment other than Hep B, Hep C, and if we really start this, diabetes will goes up, because one of the important treatment protocol is steroid. That is the problem.
Yes, I understand.
Or sometimes we use tacrolimus. It also increases the CNI diabetes level. That is the question. That is the problem.
Yes. That is
If the patient has membranous, if the patient has membranous and PLA2 is negative, then you can assume that it is not primary membranous. So it could be secondary to hepatitis. So it's something.
So
Dr.
serology in that case would be useful.
I have a question to you. What is the role of immunohistochemistry in renal biopsy specimen? Is there any role?
Yes, we do it, for example, for fibrillary to confirm, but fibrillary you already know what it is, and then we can do DNA JB9 immunostain, PLA2R. We sometimes do it on the membranous cases.
Yes.
For myoglobin, for example, in patients who have got rhabdomyolysis, to confirm that the casts that you're seeing is not RBC and it's actually myoglobin, we sometimes do myoglobin immunostain. So there are few immunostains that we do in nephropathology, in native kidney biopsies.
A few days ago, we have a renal biopsy report showing that this is a myoglobin nephropathy, and the histopathologist suggests us to do the immunohistochemistry. So, do you do it in your regular practice?
We do it, but I mean, myoglobin has its own classic structure. So if you're seeing it by tubular, I mean, you're just going to be confirming the diagnosis, right? But you should already be seeing it by your light microscopy. So even if you don't have it, you have it, the patient CK, for example, is very high. You already know that diagnosis. So there is no point spending, we do it definitely.
But,
It's not, I'm not saying that we don't do it, but it's not essential. I usually find out the case saying that the casts that I'm seeing are very suspicious for myoglobin, and you can start treatment or keep whatever you need to do.
Thank you. Thank you.
Another one thing, previously there you discussed about what is the protein level of doing biopsy in diabetes. Actually, I think I got in one article, it is maybe 8 gram in initial proteinuria or
8
rising.
gram?
Yeah.
Wow,
Initial,
that's a lot, yeah.
and it is rising proteinuria and rising. Yeah, not explained by other diseases.
Right,
so
right.
you may do renal biopsy and active lesion and other things.
I do it even if it is 1 gram. I've done it.
Yeah.
The reason is the patient has an A1C of 6.2 and the patient's blood pressure is 120/80. Patient is on ASARB plus SGLT2 inhibitor and spironolactone. Patient has 1 gram of protein. I just convince the patient that I don't think it is typical diabetes and no retinopathy. So I did it.
Yeah,
No,
exactly.
that is the universal recommendation when there is no retinopathy. What is active when there is any active lesion or proteinuria, hematuria cast, and other than that, initial proteinuria, just the first diagnosis, it is if it is 8 gram or rising proteinuria or rising creatinine, not explained by other disease. And we regularly do renal biopsy in diabetic patient, and usually we got some different diagnosis. Sometimes we got different diagnosis. Sometimes we got diabetes, only diabetes. That is actually true.
Yeah. And one thing
So
I'll
Dr.
say, like,
Huda, can I say something?
Yeah.
In concerning the comments of Dr. Abhishek, I can remember that one of our senior colleagues, Dr. Nabiul Hassan Rana, has had his thesis on the diabetic nephropathy, non-glomerular diabetic disease. He was searching on the basis of, on the clinical basis. He performed biopsy on diabetic patient with some indications, and it was found that some of 25% of the patients had non-diabetic glomerular disease. So far, I can remember. Thank you.
Yeah, already I think Abhishek mentioned 60% diabetic and for 20% mixed and 20% non-diabetic.
Yes, agree. I completely agree with that fact. And in fact, my mentor used to say that if we do not find 15% patients with pure diabetic nephropathy, we are not biopsying enough. So don't be afraid to biopsy that diabetic patients whom you have a clinical suspicion that patient may have something else.
Yeah.
Agree.
even in diabetic patients, I mean, biopsy is a lot of times very useful because let us say there are many scenarios I can say about. Like one of them is your diabetes may be well controlled. You don't have advanced diabetes, but you're seeing severe food process effacement and things like that. It's a minimal change at that time. It's not necessarily the diabetes is causing it, right? So patient has a well-controlled diabetes, but they're having nephrotic range proteinuria or higher, and the diabetes is, as I said, well controlled, then it could be just, minimal change disease. That those cases you may be able to treat with steroids and not kill the patient. There are again a lot of patients with diabetes who have got concomitant IgA nephropathy or IgA deposition. So those would have you're basically going to go and look for an infection, underlying infection associated GN. Some patients, of course, like elderlier, you would be able to know about the chronicity of the disease, how much time more you have, or how the kidney is doing. So chronicity is another important one. And even in young patients with relatively young onset, I think it's becoming more and more common. Even in my last 1 week, I had 3 or 4 biopsies where the patient is in the 30s, 25, 30, 40-year-old, and relatively young onset of diabetes, but the diabetes is so advanced. They were not coming to the physician, but then by the time that the biopsy is done, now it's, advanced. More than 70% of the gloms are gone. And I look at the HbA1c, it's like, it's like 6, 5.5. So it actually raises the question how reliable the HbA1c or the tests are. Because I think there is a lot of variability that we don't know still. We take that 5.5 or 5 as a cutoff thing, but it may not be the same for every single patient. It could be different. So every person has their own individuality. So while it works for most people, if you have a clinical suspicion that something else is going on, I think it's worth investigating more.
Our ophthalmologist colleague usually says that it is not the control of the diabetes, it is the duration of the diabetes which can involve the eye. Actually, so I don't know it is true for kidney or not. It is not the level or control or duration, but I think there's some genetic predisposition which patient has involved the heart first, which patient has involved the vascular system first, which patient has involved the renal first. I think this is the genetic predisposition, or not all the patients. You see, some patients has diabetic kidney disease, some patients have diabetic nephropathy. There's some difference between diabetic kidney disease and nephropathy. There is a proteinuria followed by progression of the renal failure or renal function. This is diabetic nephropathy. But in case of diabetic kidney disease, patient may develop renal pathology without proteinuria. So,
definitely.
So this is I think there is also a research era. Which patient develop which disease or which organ first? It may be due to genetic predisposition of that patient.
Professor
Yeah, a lot
Bhutta,
of times we
40 to
see
60% diabetic patient is without albuminics. So there is a established literature 40 to 60% without albuminic diabetic patient. So
Yes,
this
sir.
is coming. Your idea is all right.
Yes,
yeah,
sir.
and actually, as I said, like in diabetic patients, the glomerular disease and tubulointerstitial diseases can go concomitantly or be separate. We see a lot sometimes the kidney, the glomeruli are fine, but the tubulointerstitium is completely wiped out because of diabetes. And the vice versa. A lot of times you may see very advanced diabetic nephropathy in the glomeruli, the glomerular disease, the glomerular component, but the tubulointerstitium is still surviving well. So there are, those differences too. So the tubulointerstitium, the vessels, the glomeruli, they can behave differently.
That's why in diabetic, we find the patient slow losing nephropathy. As sodium is a very important point. It's recurrent hyponatremia. That is the point.
Bhaiya, you are muted. Imtiaz
अभी
bhai.
आपने unmute करो इम्तियाज भाई.
So excellent points and excellent discussion. I'm sure what is most important is for the faculty in Bangladesh, I would again say that since we have the distinct advantage of having Dr. Shahriar Amin, Professor with us, we should take advantage of this situation. So, I mean, he's available on the internet. We could ask questions, maybe help us set up a curriculum for our students so that, you know, they're more equipped with nephropathology. And, you know, there is another issue is we need to discuss about is transplant nephrology and how our pathology has been not so adequate. And he could help us a lot with that in Bangladesh, especially. So, Dr. Mahfouz, are you there? I don't think he's there. So it is almost midnight in Bangladesh, and thank you so much for hanging in there, everyone. So I guess if there are any last words, Tanvir, if you have any last words, otherwise I would conclude the session. And thank you so much, the distinguished panelists and excellent lecturers. It has been a great event. I think the students are a little overwhelmed, but inshallah, next time. I think we have to know these things because whether we can do it or not, the question is we have to understand the standard of care for these things. You know, yes, because we don't have everything available, but we have to know those because
Yeah,
you know.
great. That's a great comment.
Okay. Good night, everyone. Assalamu alaikum. Have a wonderful
Thank
day.
you,
very
thank
much.
you, everybody.
you.
Thank you,
Thank
everybody.
you.
Thank you. Assalamu alaikum.
শারিয়ার দেখা কথা হবে শারিয়ার
Yeah, inshallah.
Bye bye.
তুমি বাড়িতে আসো না
আসবো ইনশাল্লাহ দেখি এই বছর আসার ইচ্ছা আছে sometime.
Dr.
আসলে
Sharia, did
নিশ্চয়-
you remember
আসলে
in the
দেখা
Kidney
করবেন।
Foundation?
Yes,
Kidney
yes, of
Foundation?
course. জি, definitely. Yeah.
আসলে
Yes.
Also,
দেখা
Harun
করবেন,
invited you. So,
Yes,
excellent, excellent. Your lecture is excellent.
শোনো, শারিয়ার তুমি আসলে আমার একটা আগে জানিও, তাহলে আমি আমার স্টুডেন্টদেরকে বা চিটাগাং নেফ্রোলজিস্টদেরকে নিয়ে তোমাকে নিয়ে একটা সেশন করতে পারবো আমি, হ্যাঁ?
Okay, sure.
Doc-
আপনি অনলাইনে যদি করতে চান I'm available. Sometimes আমি এখানে আমাদের এই নেফ্রোলজি স্টুডেন্টদের জন্য আমাদের তো ফেলোশিপ আছে। So I actually do once a month nephropathology webinar, সেমিনার ওদের জন্য। So I could just share those same things বাংলাদেশের জন্য। And এটা একেবারে in person আসা কোনো জরুরি না আজকাল, তাই না? আপনি অনলাইনেই করতে
না,
পারেন।
তুমি হয়তো
আপনারা যদি অর্গানাইজ করেন I would definitely show
আচ্ছা
some
ঠিক
of
আছে, অনলাইনে তো করবোই।
প্রফেসর হুদা যখন করবো আমারে জানেন।
স্যার, হ্যাঁ। আর তুমি তো চিটাগাংয়েরই ছেলে, নিশ্চয়ই চিটাগাং আসবে বেড়াইতে, সেটাই জন্যই
অবশ্যই।
বলতেছি।
অবশ্যই।
Taking advantage.
স্যার,
Anyhow,
ও তো
ইনশাল্লাহ আমরা
আসবেই,
Kidney
ও তো চিটাগাং
Foundation
আসবেই। যেহেতু
ইনশাল্লাহ।
চিটাগাং আসবে সেজন্য। আর ও স্যার,
হ্যাঁ,
ও কিন্তু স্যার ঢাকা মেডিকেলের, এটা জানেন তো।
কোন ব্যাচের?
K51
51
আমি আর তানভীর আমরা একই ব্যাচের।
ও আচ্ছা, ভেরি গুড। আমি K31।
আচ্ছা জি ভাইয়া।
K31। আমরা দিনুভাই পরের ব্যাচ।
হুম,
Thank you very much. So nice.
Thank you,
Excellent.
thank you.
খুব
We are
ভালো।
delighted to see your lecture.
ইমতিয়াজ ভাই, আপনাকে ধন্যবাদ, আপনি এরকম একটা সেশন
Thank you, ভাই।
অ্যারেঞ্জ করছেন। সবাই
আমি
আরে উনি তো চালিকা শক্তি।
না,
উনি এর আগেও ওই যে MGOS এ করছিল, ওইটা এত মজা লাগছে। আজকেও এত এনজয় করলাম। It is
না,
about 12.
এটা স্যার আমাদের এখানে সাংঘাতিক ভাবে আন্ডার ডায়াগনোসড, এই জন্য আমাদের বেশি ভালো লাগছে স্যার।
কোনটা?
এই যে আমজিআরএস আমাদের দেশে এটা ডায়াগনোসিস হয়ে বলেই চলে, আর আমাদের তো কাপ্পাল আমরা খুব কমই স্টেনিং এ দেয়। ওই সবসময় ওই যে গদবাদা আইজিজি আইজিএম, যে আইজিএস C3 C4 আর ওই যে কি বলে এগুলিই দেয়, C1 কি এগুলিই দেয়।
প্রফেসর হুদা, বাংলাদেশে একটা কথা, নেফ্রোলজিস্ট মানে প্যাথোলজিস্ট, নেফ্রোপ্যাথোলজিস্ট নাই বললেই চলে। নাই বললেই চলে।
যেটা বললো পাঁচটা, যে পাঁচটা বললো, এখন আমি চিন্তা করছি
কাপ্পা
বাংলাদেশের
লেপ্রা করলে
আপনাদেরকে এই কথাটাই বলবো, ভাই আপনারা এই পাঁচটা দেন, আর কিছু লাগবে না।
পাঁচটা,
ওদের-
ওই যে
ও তো
কাপ্পা
বললো
লেপ্রা করলে
আইজিজি
80% হয়ে গেল।
আইজিএস C3 কাপ্পেলামডা, এই পাঁচটা, তাই তো?
হ্যাঁ, কাপ্পা লেপ্রা
এই
করলে
জি-
80% বলে গেলাম আর কি, বুঝে বললাম।
এম লাগবে না, এম লাগবে না,
এম লাগবে না, C31
Q1
রূপাক
লাগবে,
ছাড়া লাগবে না।
C1
আচ্ছা,
Q
আমরা-
লাগবে।
হ্যাঁ,
C1
ইনশাআল্লাহ।
কেউ লাগবে না।
যাক, এই যে জিনিসগুলি শিখলাম, এইটাই তো বড় জিনিস।
জি স্যার, জি স্যার, এই যে আমি
আলহামদুলিল্লাহ।
এটা
আচ্ছা,
বললাম।
আরেকটা হলো ডায়াবেটিস থাকলেও যে সুপার ইম্পোজ থাকবে না এবং স্টেরয়েড দেওয়া যাবে না, সেটাও ঠিক না। উনি যেটা বললো, স্টেরয়েড দিয়েও তো আমরা চিকিৎসা করতে পারি ডায়াবেটিস কন্ট্রোল রেখে, যেটা আমরা
হুম।
প্রায় ফেস করি। ভেরি
জি।
গুড, ভেরি গুড।
থ্যাংক ইউ,
থ্যাংক ইউ এভরিবডি এগেইন।
Thank you. Assalamu alaikum.